the dynamic fold change, and the high accuracy of treatment response monitoring. This is the future direction. From this microRNA, we can do the translational research, and we can make a microfluidic chip which can actually predict the treatment response during the course of the treatment, if the patient is responding to the treatment or not, so that we can actually track the patient will be resolve their inflammation or the disease burden after the 6 months or not. So this will be the flow of the direction of the process. And I'm concluding that the immune regulatory microRNAs, microRNA 27A3P, microRNA 99B5P, and microRNA 120Y5P serve as highly sensitive and specific biomarkers of TB treatment response with strong potential for point of care biosensor development. I am greatly acknowledge the Department of Pharmaceuticals, Ministry and Chemicals, Fertilizer, Government of India for supporting this work through National Institute of Pharmaceutical Education and Research NIPER, and we gratefully acknowledge the ICMR RMRIMS for providing us the site and access to the molecular biology lab where all the experiment work has been conducted. This is my research team. Thank you.
So you are talking about the biosensing, right? Yeah, isolation and then the mRNA biosensing,
Yes, sir.
RNA biosensing for the biosensing.
Yes, sir.
So what will be the selectivity or sensitivity? The
Like
biosensing.
it will be for DNA aptamers. For the specific microRNA, we will commercially procure the aptamers, DNA aptamers, which will be complementary to that microRNA. So the aptamers will be placed in the biosensor. When the patient's blood for isolated PBMC will be given to that biosensor, it will be selectively bind to that aptamer, and it will give the signal which will generate this graph, and we will identify the patient is having this inflammation or not.
Is there any label for that?
Yes, the level is, we are still, it is the future direction, sir. We are still working on that. The level will be the expression pattern, the gene expression, how much it is. According to that, we will select the level.
Thank you.
Thank you, sir.
Thank you, Ms. Priyanka, for the wonderful talk presentation. May I request us to present a token of appreciation to Priyanka? आगे चलेगा. Our next presenter is Dr. Riya Mittal from Lady Hardinge Medical College, Delhi. May I request her to be here?
Good morning, respected chairperson and all our esteemed listeners. I am Dr. Riya Mittal, junior resident, Lady Harding Medical College, and I'll be presenting my original research, a prospective study to evaluate the dermatological and psychological response to pharmacological therapy in patients of psoriasis and their caregivers as relevant. So, to give a brief intro into this study, psoriasis is a chronic immune mediated inflammatory disease. And in 2014, WHO actually recognized it as a major public health issue. Psoriasis is not only marked by skin lesions, but the visible nature of these skin lesions themselves and the resulting disfigurement can greatly influence the quality of life for both patients and those who care for them. Increasing evidence shows that psoriasis could lead to depression, and depression in turn exacerbates psoriasis, which may result in a vicious cycle of psoriasis and depression. Psoriasis has a significant impact on global public health, resulting in substantial physical, psychological, and economic burden. There is currently no cure for this condition. However, the advent of biologic therapies has substantially improved the treatment for moderate to severe psoriasis, which marks the major reason for the psychological stress in psoriasis patients. So, why did we conduct this study? The results of a lot of meta-analysis have been conducted previously on this condition and the impact of therapies on various dermatological and psychological factors. So, the results of a meta-analysis involving 1048 patients showed significant improvement in many aspects of psychological burden with the use of psychosocial interventions. However, another Bayesian meta analysis study conducted along the same lines showed a bit of contradictory results, where, when comparing the use of psychosocial interventions with treatment as usual, along besides treatment as usual did not show any significant improvement in patients. So these contradictory results show a need for higher quality, more comprehensive studies to analyze the psychosocial impact of psoriasis and how to address this psychosocial burden in patients with psoriasis, and whether our current management protocols are addressing this issue of psychosocial burden in patients of psoriasis, or do we need to use some other psychosocial interventions to address this issue. So, this study was planned to fill this gap. Aims and objectives. The primary objective was to study the psoriasis area severity index versus therapy following 8 weeks of treatment in patients of psoriasis. Psoriasis area severity index is a dermatological marker, which is a quantitative marker and is used to quantitatively see the impact of therapy on psoriasis patients. To study change in depressive symptoms using patient health questionnaire and Beck depression inventory following 8 weeks of treatment in patients of psoriasis, to study change in depressive symptoms using patient health questionnaire and Beck's depression inventory from baseline to 8 weeks of psoriasis treatment in caregivers, and to study change in quality of life using DLQI in following 8 weeks of treatment in patients of psoriasis, and to study change in quality of life scores using family dermatology life quality index from baseline to after 8 weeks of psoriasis treatment in caregivers. So methodology. This study was conducted in Lady Hardinge Medical College in Dermatology and Pharmacology department. 32 patients were recruited from the dermatology department following the inclusion and exclusion criteria. In inclusion criteria, newly diagnosed or treatment naive or patients being started on a new treatment were included. Patients started pharmacological treatment with topicals like corticosteroids, vitamin D analogs, emollients, calcineurin inhibitors, and or systemic corticosteroids. Non-biologicals or biological agents were included. Age more than 13 years patients were included. Patients receiving phototherapy or laser therapy were excluded from the study. Patients with known history of any diagnosed psychiatric disease or receiving treatment for the same were also excluded. Patients having any other comorbidity or chronic disease affecting their depression score were also excluded. So this is was the study design for this study. Newly diagnosed or patients starting a new treatment were enrolled following exclusion and inclusion criteria. 32 patients were recruited. PSI, DLQI, FDLQI, PHQ9, and BDI was done for both patients and caregivers at baseline. After 8 weeks of psoriasis treatment received by the patients, the parameters were repeated again after 8 weeks of therapy. That is PSI, DLQI, FDLQI, PHQ9, and BDI. So for our results, we compared PSI 75 response by therapy. So PSI 75 is at baseline, whatever PSI was there was compared with after 8 weeks of treatment. So if there was a 75% improvement from baseline, that is called PSI 75 response. So we compared with the patients receiving biological therapy versus non-biological therapy. Fisher's exact test was used to see whether there is any association between using biological therapy versus using non-biological therapy. So we found an odds ratio of 12, which can be interpreted as there is 12, the response is 12 times higher, like PSI 75 was achieved in was achieved in 12 times higher in patients receiving biological therapy as compared to patients receiving non-biological therapies. Then we have DLQI scores. So in dermatology life quality index, a mean difference of minus 4.22 plus minus 1.26 with a significant p-value of less than 0.05 was seen between baseline and after 8 weeks of therapy. Comparing this with already present literature, we can ascertain that this was a clinically meaningful difference. Then grading of depression in patients with psoriasis at baseline and after 8 weeks of pharmacological treatment, we see that at baseline, 15.62% of patients reported moderate to severe depression. However, by the end of 8 weeks of therapy, none of the patients reported moderate severe depression on the PHQ-9 scale. While 81.25% percent patients were reporting mild depression, only 21.87% patients reported mild depression after 8 weeks of therapy. So, this actually shows a significant improvement in patients' quality of life and depression scoring after 8 weeks of pharmacological therapy. The change in mean BDI scores from baseline was not found to be clinically meaningful when we look at the previous data, so it has not been reported here. Then comparison of FDLQI scores. So a mean difference of minus 2.09 plus minus 2.24 with a significant p-values was obtained. There are not many studies which report FDLQI scores as per our literature review. However, when we compare this significant decrease with the DLQI scores, we can report that it has a clinically meaningful value. However, due to a lack of previous literature, we cannot strongly say this. Comparison of PHQ-9 scores in patients, a mean difference of minus 3.50 plus minus 2.05 was obtained. This is also a clinically meaningful change when compared with previous literature. So, proportions of caregivers of patients with psoriasis reporting depression at baseline day 0 and after 8 weeks of pharmacological treatment using PHQ-9. So, at baseline, 91% patients, caregivers reported mild depression. However, only 14% of those caregivers reported having mild depression after 8 weeks of their patients receiving the therapy. So, this is a significant change where the caregivers' quality of life and depression scoring has also improved after their patients have received therapy. Proportions of caregivers of patients with psoriasis reporting depression at baseline and after 8 weeks of pharmacological treatment using Beck's depression inventory. So, on Beck's depression inventory, while 31.82% patients reported having mild depression at baseline, only 4.53% patients reported having mild depression after 8 weeks of therapy. So, for conclusion, in this study, we can see that there are notable clinical improvements in psoriasis severity scoring, where PSI 75 was achieved in 19% of patients with psoriasis, and PSI 50 was achieved in 48% of patients. This was parallel by improvement in health-related quality of life markers like DLQI, PHQ-9, and BDI scores, which were also significantly decreased among patients, indicating that a reduction in skin disease burden and depressive symptoms, with the proportion of patients reporting moderate to severe depression dropping to zero after 8 weeks. Similar patterns were also observed in caregivers with significant reductions in FDLQI, PHQ-9, and BDI scores, highlighting improvements in quality of life and mood correlating with patient improvement. So, this also marks our future trend. So, we have seen that there is a significant association between use of biologics and clinical improvement, that is PSI. So, now it is important to know whether introduction of biologics early in the therapy without patients achieving a status of moderate to severe psoriasis, whether we can drop this psychological burden or not. So, this warrants a further analysis of whether early initiation of biologics might be beneficial and in reducing the psychosocial burden in psoriasis. Thank you. Any questions? Yes, sir. So, sir, in biological treatments, we have TNF alpha inhibitors, interleukin 23 and interleukin 17 inhibitors, and interleukin 22 inhibitors right now for psoriasis therapy. So, this is a part of a normal physiological mechanism of psoriasis, which is actually uh, uh, dysregulated in psoriasis. So those points are targeted in biologic therapies. However, in non-biologic therapies, we have corticosteroids, emollients, apremilast, and methotrexate-like therapies which target inflammation in itself or keratinocyte proliferation. Yes, sir, drug-related only. Thank you, sir. Any questions? Yes, sir. Yes, sir. Sir, PHQ9. So PHQ9 has nine questions,
Yes.
and BDI questionnaire has 22 questions in it. So these are actually patient administered questions only. So they can attempt it themselves. And I was using both Hindi and English versions of the questionnaire, so they were able to attempt it by themselves. So I can just, so the patients would either.
Patients were comfortable in answering 31 questions at a time.
So
Sometimes it becomes
it would
very
take a
difficult.
lot of time.
When practically you talk,
Yes, sir.
many
So,
times
so
patients they do
that's
not
why
give the
actually
time.
I have a very small sample size. Like I was able to get very less patients because of that.
And then second thing in methodology, any dropout because it was a prospective design. Many times what
Yes,
happens,
sir. Yes, sir. So
people
I
come
have
for the
only,
first round, they do not come for the follow-up.
sir, I have only considered the patients for whom I could take a baseline and a follow-up as well.
Only those patients. There
Yes,
was
sir.
no dropout, nothing.
No, no, sir.
All the patients they have done they came for the follow-up.
Yes, sir.
And ethical clearance was obtained.
Yes,
It was
ethical
from the
clearance was obtained from our scientific community and from DU, Delhi University.
But one more thing, I am not sure because you have used the term, the depression scale.
Yes, sir.
I wish you could have, though it is a patient reported study, I wish you could have used something relevant to the DSM also. You're getting my point. Saying somebody is
Sir,
suffering because
yes,
of
sir.
psoriasis,
Sir, actually,
because he has gone up to the level of moderate
mhm.
depression. So depression itself, until unless we identify through the DSM criteria, it is very difficult to say by using any patient reported, questionnaire.
Sir, actually, one of the exclusion criteria was that the patient was actually not clinically diagnosed with depression. So, what we were trying to do in this study basically was to just look for whether there are any depressive symptoms in the patients or not.
Study was conducted on OPD basis or inpatient basis?
So, on OPD basis.
And difficult to say. OPD
Yes, sir.
basis, we do not do go for diagnosis for all the
So
patients.
we are not diagnosing any patient with either moderate or we are not diagnosing any patient with depression.
I'm
We are
just saying,
just
no, I agree. I said I wish you could have used the DSM scale also parallelly. You're getting my point.
so
Then I think
for
the
that.
relevance could have been more.
Sir, actually, for that, I would have required someone from the psychiatry department
Psychiatric,
to be there with me every time I was
some
considered.
psychologist.
Yeah,
The
some psychiatrist.
results could have been more better.
Yes, sir,
Getting my
yes, sir, absolutely.
But otherwise, it was a very good study.
Thank you so much.
That is all.
Thank you, Dr. Ria. We will request our chairperson to kindly honor Dr. Ria. Our next speaker is Anupa Eldos from CMC Vellore.
Good morning, all. I'm Dr. Anupa Eldos, postgraduate from CMC Vellore. So today I'll be presenting about the research we did in our college the prevalence of the catechol O methyl transferase RS4680 polymorphism in spine surgery patients. So this catechol O methyl transferase gene, it is located on the long arm of chromosome 22 and contains 6 exons. So as we all know, this COMT gene, it codes for a enzyme called COMT enzyme, that is the catechol O methyl transferase enzyme. This enzyme is responsible for the conversion of active catecholamines like dopamine, norepinephrine, epinephrine to its inactive metabolites, and it gets excreted. So we were going to look into a polymorphism, that is the single nucleotide polymorphism COMT RS4680 in the gene that codes for catechol O methyl transferase. So in this polymorphism, which is also called as Val158 met polymorphism, there is a substitution of guanine to adenine nucleotide in exon 4 of COMT gene. So as a result, there will be formation of methionine instead of valine, and this will produce decreased COMT enzymes. And as a result, there will be more or increased dopamine in the blood. So here, we are doing this study because there is so much of clinical implications with this COMT enzyme. Like we all know, it is very important for psychiatric diseases, this dopamine and all those things. And even in the case of pain sensitivity is also shown to be increased in patients with decreased COMT enzyme or in the patients with single nucleotide polymorphism. So this is basically by two mechanisms, that is increased epinephrine or increased dopamine. So when there is an increased epinephrine, it will activate the beta 2 and beta 3 adrenergic receptors. As a result, there is increased release of pro-inflammatory cytokines like TNF alpha and interleukin 6. As well as in the other pathway, that when there is increased dopamine, it will cause decreased striatal P and mRNA expression and decreased MET and Luke enkephalin. So as a result of both these pathways, it will cause an increased pain sensitivity in the patients with the single nucleotide polymorphism. So our objectives were, primary objective is to evaluate prevalence of COMT RS4680 polymorphism in spine surgery patients. And secondary objective was to evaluate the association between COMT RS4680 polymorphism and pain sensitivity in acute postoperative period after spine surgeries. So a sample size of 95 patients were calculated with reference to EC Tan et al. The prevalence of RS4680 polymorphism is 57.3, that is having AA or GA polymorphic variant with precision of 10% and 95% confidence interval. So coming to the participant criteria, so our patients were above 18 years of age, receipt of general or general with regional anesthesia, and admission for a single spine surgery, and the subjects were prospectively enrolled in the study after investigators obtained the institutional review board approval and written informed consent from the patient. The exclusion criteria were, the patients were excluded if they had a second trauma site, a history of mental illness, neurological conditions, and hepatic or renal diseases, had undergone a surgical procedure within the past 1 month, history of allergies to any of the protocol medication, and did not consent for the study. So after receiving IRB approval, informed consent was obtained pre-operatively from the patients undergoing spine surgery in Christian Medical College, Vellore, and patients who met our inclusion criteria. And 3 ml of blood was collected pre-operatively in an EDTA tube, and pain score was analyzed at 0, 6, 12, 18, and 24 hours after regaining consciousness post-surgery using a universal pain score assessment tool. DNA was extracted from the blood samples and COMT RS4680 polymorphism was checked by RFLP method. So here the restriction enzyme used was NLA3. Statistical analysis was done by SPSS version 21. So this is the universal pain score which we used for our assessment of pain post-operatively. So coming to the results, in our study population of 98 patients, 61% of the patients were male and 39% of the patients were female. Out of the number of participants from our study group, there were both Bangladeshi patients and Indian population, and from 16 of them from Bangladesh and 82 were from India. Out of the Indian population, most of the populations were people were from West Bengal, Jharkhand, Bihar, etc. So the number of patients with GG, GA, and AA genotype. Here, the GG type is the wild type, and AA type is the mutated type. So the GG type was 32.6 percentage, and GA was 55.2 percentage, and AA was 12.2 percentage of the study population. We calculated the allelic frequency by number of copies of the allele by total number of all alleles at that locus, and we found that the G allele frequency was 0.602 and A allele frequency was 0.398. So here we can see a gel dog picture where we can see both the homozygous as well as the heterozygous group. The homozygous AA, that is the single nucleotide polymorphic group, and GG is the wild type. So we calculate Hardy-Weinberg equilibrium is calculated. So we found that the observed count was almost equal to the expected count of observed count of GG was 32 and the expected count was 35.5. Similar results were found for GA and AA type. We did a chi-square test, and chi-square test it showed 2.209. P-value of 0.138 was received. So this p-value indicates that there is no statistically significant deviation from the Hardy-Weinberg equilibrium in our sample, the conventional 0.05 significance level. So secondary objective was to find the association between the single nucleotide polymorphism COMT RS4680 and pain. So here we found that the patients with AA group had maximum pain, and that is in accordance with our study or according to the literature reviews. So we saw that in the 6th and 12th hour the patients experienced maximum pain, and the maximum pain was for AA group, that is the polymorphic group, and the least pain was for GG group. Even though the result was not statistically significant, difference between the pain was not statistically significant. Coming to the discussion, so our primary objective was to find the prevalence of single nucleotide polymorphism RS4680, and we found that the G allele frequency was 60% and A allele frequency was 40%. This was in almost similar to the 1000 genome project results, where the G allele frequency was 56% and A allele frequency of 44% in South Asian population. Pain perception is a complex process that is influenced by a variety of environmental and genetic factors. Consistent with previously reported results, the VAL158 MET single nucleotide polymorphism showed a marginal but not statistically significant relationship with pain sensitivity. However, another study from Geneva found that the patients with COMT RS4680 GG genotype had lower postoperative pain score than GA or AA genotype. So to conclude, the allelic frequency in our study population was G allele frequency of 60% and A allele frequency of 40%. Genotype distribution in our sample adheres to the Hardy-Weinberg equilibrium. The Val-Met polymorphism showed a marginal but not statistically significant relationship with pain sensitivity in our study. I want to acknowledge the Indian Pharmacological Society for giving me this opportunity to present my research. And I want to thank IRB, CMC Velu, Fluid Research Grant, CMC Velu, and the faculty, staff, and PGs of Department of Pharmacology and Clinical Pharmacology, CMC Velu. Thank you.
Anupa, you mentioned about the DG and G.
Yes.
Okay. So in this case, if you show that plane,
Okay.
okay, there is no quite significant difference.
Yeah, actually, we had powered the study because our primary objective was to find the prevalence, because there are no much studies about prevalence in Indian population. There is one single study which we have used for sample size calculation. So that is from European patients basically settled in Europe, Indians from Europe. So we had first wanted to do a prevalence study in our population. So the study was actually powered for the primary objective. I think that might be one of the reasons, because we saw that pattern even though it was not statistically significant. So our future goals are to actually continue with the the pain scoring, association between pain scoring and morphine consumption. Even we have seen there is association between morphine consumption also. So we will be doing future studies on. First, we had to analyze the prevalence in Indian population.
Thank you.
Thank you, sir.
Any question?
Thank you, Dr. Anupa. Request sir to kindly present a token of gratitude to her. Thank you. Kindly be should we be you will be the part of our next speaker is Dr. Hina Rathi. She is from NIMS University, Jaipur.
Good morning, respected delegates. I, Dr. Hina Rathi, want to present my research on the topic effectiveness of prophylactic inhaled budesonide on post-operative sore throat in patients operated general anesthesia with endotracheal intubation. Post-operative airway complications, including sore throat, cough, and harshness of voice, are very common adverse events following endotracheal intubation under general anesthesia. Budesonide is an anti-inflammatory corticosteroid. Its rapid onset and local action make it potentially effective prophylactic intervention to prevent post-intubation airway morbidity without any systemic side effects. Therefore, this study was conducted to assess the effectiveness of prophylactic inhaled budesonide in reducing post-operative sore throat, cough, harshness of voice in patients undergoing surgery under general anesthesia with endotracheal intubation. Inclusion criteria of the study: patients of either sex, age group between 20 to 60, were enrolled for the study who were ready to give the informed consent and undergoing the surgery under general anesthesia requiring endotracheal intubation. Patients who are non-smoker and belong to ASA grading class 1 and 2 were included in the study. Exclusion criteria of the study: patient with the history of preoperative sore throat, cough, and harshness of voice, patients with recent upper and lower respiratory tract infections, or patients with any chronic respiratory disease. Patients who were allergic to the test drug were excluded from the study. patients who are already on analgesic or any steroids and will require more than 2 attempts for intubation, and patients with anticipation of difficulty in endotracheal intubations were excluded from the study. Material and methods of the study. It was a randomized, controlled, single blind, prospective interventional study. The technique for the study: the patients were divided into 2 groups. Each group contains 41 patients by systemic sampling technique. Patients were divided into odd number group and the even number group. Odd number group patients received test drug, which was budesonide, and even number group patients received placebo. Patients were asked to inhale single puff of 200 microgram budesonide and placebo inhaler according to the group allocation in pre-anesthesia room. After 10 minutes, the patient was taken for anesthesia. During the perioperative period, vital parameters of the patients were noted and extubation was performed by anesthesiologist. After arrival in the post-anesthetic care unit, patients were questioned at 2-hour and 24-hour whether he or she has experienced any sore throat, cough, or harshness of voice. Results of the study: in this study, there were 29 male patients and 12 female patients were taken in the non-experimental, which was the placebo group, and 31 male patients and 10 female patients were included in the experimental or the test group, which was the budesonide group. Table 1 is showing the effectiveness of placebo group in terms of post-operative sore throat, cough, harshness of voice by MC-NEMAR test statistics. By this test, we have seen that there were 63.41% patients who were having sore throat at 2 hours as well as on 24 hours. But there were 24.39% patients were there who were having the sore throat at 2 hours but not on 24 hours. There were 7.32% patients were there who were not having sore throat at 2 hours, but they developed sore throat after 24 hours. And there were 4.88% patients were there who were not having sore throat at any point of time, whether it is 2 hours or 24 hours. The MC-NEMAR test shows the results of 3.76 and the p-value was 0.052, which was not significant. For the cough, there were 31.71% patients were there who were having cough at 2 hours as well as on 24 hours. There were 41.46% patients who were having cough at 2 hours but not on 24 hours, and there were 4.88% patients were there who were not having cough at 2 hours but they developed cough after 24 hours. There were 21.95% patients were there who didn't have cough at 2 hours or 24 hours. The MC-NEMAR test result shows 11.84 and the p-value was 0.00056, which was significant. For the harshness of voice in the placebo group, we have seen that 58.54% patients were having harshness of voice at 2 hours as well as on 24 hours. There were 17.07% patients were there who were having harshness of voice at 2 hours but not on 24 hours. There were 0 patients who were having harshness of voice not on 2 hours but developed on 24 hours. There were 24.39% patients were there who didn't have harshness of voice at 2 hours as well as on 24 hours. The MC-NEMAR test result shows 7 and the p-value was 0.0082, which was significant. This table 2 shows that test results for the test group in terms of postoperative sore throat, cough, harshness of voice by MC-NEMAR test statistics, in which we have seen that there were 12.19% patients who were having sore throat at 2 hours as well as on 24 hours. There were 41.46% patients who were having postoperative sore throat at 2 hours but not on 24 hours. There were 0 patients who were having sore throat at who were not having sore throat at 2 hours but developed at 24 hours, and there were 46.34% patients who were not having sore throat at any point of time. And cinema test shows the results of 17, and the p value was less than point triple zero one, which was significant. For the cough, there were 9.76% patients who were having cough at 2 hours and 24 hours. There were 21.95% patients were there who were having cough at 2 hours but not on 24 hours. There were zero patients who were not having cough at 2 hours but developed at 24 hours, and there were 68.29% patients were there who was not having cough at 2 hours or 24 hours. The MCNMR test shows the results of 9, and the p value was 0.0027, which was also significant. For harshness of voice, we have seen that there were 12.19% patients were having harshness of voice at 2 hours and 24 hours. There were 48.78% population were not having harshness of voice at 24 hours, and there were zero patients who complain about harshness of voice at 24 hours but not on 2 hours, and there were 39.02% patients were there who were not having harshness of voice at any point of time. For this also, the p value was less than 0.001, and it was also significant. Then the table 3 shows the comparing post-operative sore throat, cough, and harshness of voice for the patients at 2 hours between non-experimental and the experimental group by using chi-square test. For this, at 2 hours, there were 87.81% patient of non-experimental or the placebo group was having sore throat. There were 53.66% population was having sore throat in the experimental group. In non-experimental group, there was 73.17 population was having cough at 2 hours, and there were 31.71% population of the experimental group complain about cough at 2 hours. And for the harshness of voice, 75.61% were complaining about harshness of voice by the non-experimental group, and 60.98% of experimental group was complaining about harshness of voice at 2 hours. The chi-square test result shows the p-value of less than 0.05 for postoperative sore throat and cough, which was significant, and for harshness of voice, it was not significant. Table 4 shows the comparing results for the postoperative sore throat, cough, harshness of voice of patients at 24 hours between non-experimental and the experimental group by using chi-square test. At 24 hours, 70.73% population of non-experimental group was complaining about sore throat, but only 12.19% population of the test group was complaining about postoperative sore throat at 24 hours. For cough, 36.59% population of the non-experimental group was complaining about cough in non-experimental group, and for 9.76% population of experimental group was complaining about cough, and 58.54% of non-experimental group was complaining about harshness of voice, and 12.19% population of experimental group was complaining about harshness of voice at 24 hours. The p value for all of them was significant. It was less than 0.05. So the discussion of the study is at 2 hours post-operative sore throat symptom was reduced in the placebo group, was lesser in the placebo comparative to the placebo group. It was lesser in the experimental group. In the placebo group, it was 87.81%, and in the experimental group, it was 53.66%. For the placebo group, it was 73.17%, and for the cough, it was 31.71%, and for the placebo group, harshness of voice was there in 75.61%, and it was 60.98% in the experimental group. At 24 hours, the results was fully evident. The placebo group was showing the post-operative sore throat 70.73%, and in the test group it was only 12.19%. For the placebo group, cough was there in 36.59%, and in the experimental group it was 9.76%. For the placebo group, harshness of voice was there in 58.54%, and for the experimental group it was 12.19%. So the conclusion of the study is the prophylactic inhaled budesonide is highly effective in reducing post-operative airway complications following endotracheal intubation under general anesthesia. The intervention significantly lowered the incidence of sore throat, cough, harshness of voice at both 2 hours and 24 hours post-operative period. Budesonide provides rapid and sustained mucosal protection, minimizes laryngeal trauma, and enhances patient comfort, establishing it as a reliable prophylactic strategy to reduce post-operative airway morbidity. These were the references. Thank you.
Thank you, Hinga. So you are telling that budesonide, that is for the 24 hours.
Yes, sir.
So next test will be next day.
No, sir. After the anesthesia, we have given this budesonide 10 minutes prior to the anesthesia, and then the patient was taken for the surgery. And after the surgery, 2 hours later, we have asked about the symptoms, sore throat, cough, and harshness of voice. Then these symptoms again they were asked about 24 hours.
So, means what is the means why these things are happening?
Because there can be multiple reason. First reason can be the choosal of the endotracheal tube. It was if it is larger in the size according to the patient's vocal cord size, then it can cause this laryngeal trauma. Or there can be the gender difference also, like the female vocal cords are little smaller than the males. That is why these symptoms can appear. Or if there is a longer surgery and the longer intubation period was there, so there can be the development of this symptoms.
Thank you.
Thank you so much, sir.
Anyone having question?
Thank you, Dr. Hina. So request her to present a token of gratitude to Dr. Hina. Please, this way. Thank you. Our next presenter is Dr. Tushar Mata from Nabi Mohali.
सर अभी कौन सी है ये रहा? Right.
So, very good morning to one and all. My name is Tushar Mata, PhD scholar at BRIC NABI and UIPS Punjab University. So, the title of my talk is Potential of GABA producing Lactobacillus brevis Lab 6 co-supplemented with modified millet bran for beneficial modulation of gut-brain axis in PTZ induced kindling. So, I will break down this title to make it more understandable. First of all, what is gut-brain communication and why we are using GABA-producing probiotics? So gastroenterologists and clinicians have also believed that there is an intricate connection between the gut and brain via the vagus nerve and also
Please keep silence.
yes. So there are metabolites which are released from the gut or the gut microbiota, which helps in the communication between the gut and the brain because most of the neurotransmitters that are being produced are in the gut. So there are receptors in the gut itself which causes the enteroendocrine signaling and causes the effect in the brain. So as we can see that there are around 30 trillion microorganisms which habitate in our gut, which constitute around 1 to 3% of our body weight. So there must be a very good reason why this amount of bacteria is present inside our gut. So we'll move towards psychobiotics now. Psychobiotics are the probiotics which are used for altering the brain functions. But the major lacunae in the research for psychobiotics is probiotics have been used for the treatment of neurological diseases without any rationale. Most of the probiotics which are used in the market for gut health are being channelized for the neurological problems without any scientific rationale, without any clinical evidence. So hereby we have addressed this research lacunae, and as I am working on epilepsy, so there is a very uh, brief imbalance between the excitatory and inhibitory system, and GABAergic neurons play a vital role in this. So we have used indigenous GABA producing strains which can help to modulate this disease pathology. So we have a repository of strains in our lab whereby we have found a very potent GABA producing strain which is Levi-Lactobacillus brevis lab 6, and we have done some of the qualitative and quantitative assay to confirm its production. Also we have done the whole genome sequences, and we have found that this GABA producing bacteria has a whole operon of GABA producing gene. So it will produce a robust GABA production framework in it, which was published recently in 3 Biotech. Further, we wanted to now check the psychobiotic potential of this strain in the PTZ model. So we have used the pentylene tetrazole, which is a very potent GABA receptor antagonist, and it produces a generalized kindling model. So we have used 3 different doses of this lab 6, and at a medium dose, we have seen a very significant difference between the pentylene tetrazole disease model and the preventive effect of this epileptic stage. Also, it shows the amelioration of oxidative stress as well as anti-inflammatory potential in the brain, particularly in the hippocampus as well as the prefrontal cortex. Also, we have done the open field test and Y-maze test, and we have seen that the behavioral deficits induced due to pelletilin tetrazole was ameliorated by the intervention of lab 6. Further, a very important sign of neuronal plasticity loss is neuronal density loss in the PTZ model, and we have seen that in PTZ the neuronal density has been suffered, but which was ameliorated by the lab 6 intervention. And further, we have done also we wanted to check how the pentylene tetrazole or overall the brain disorder can affect the gut or the colonic system or peripheral system. We have done the gut leakiness test, and we have found that pentylene tetrazole not only induced the brain alterations, but it also altered the gut parameters. It induced leaky gut. It causes the down regulation of major tight junction proteins like occludin and zone occludin. And further, it shows that in the crypts also there was a major infiltration of inflammatory markers, as well as there was distortion of the crypts. Further, there was a decreased abundance of the beneficial microbes, lactobacillus and bifidobacterium, and rheumococcus, which is positively correlated with various pathological neurological disorders, was upregulated. So this is the first study which has shown globally that pentylene tetrazole or epilepsy is linked to the gut dysbiosis or gut dysregulation, which was published recently in Journal of Neurochemistry. And the GABA producing probiotic has induced a very good amount of GABA concentration in the cecal sample, but it was not much in the hippocampus because GABA is a hydrophilic molecule which can cross the blood-brain barrier, but in minuscule amounts. Further, we wanted to check the colonization of this strain using the indocyanine green dye. The single bolus injection of indocyanine green passed as such from the gut, but when we used indocyanine green dye bound this bacteria, it was shown to be inhabited within the different regions of the gut, also in the stomach. So, GABA producing mechanism in the bacteria is solely responsible for acid protection. So, this bacteria is being very much abundant inside the different regions of this gastrointestinal tract in the gut in the lower colon region. Also, we wanted to check the safety of this strain because before submitting the strain for clinical uses, we need to ascertain whether this strain is safe for human use. We have done the in silico studies whereby we find that the strain was not showing any kind of antibiotic resistance, though putative antimicrobial resistance genes were present, but this was on the chromosome, not on the plasmid, because some of the resistance is required for all of the bacteria to survive in the gut or for the normal antibiotics which we take. Further, the virulence factors were absent in this bacteria. We did the in vitro studies and we found that the major biogenic amines which are harmful for the humans were absent. It was not showing any kind of mucin degradation, DNase degradation, or hemolytic activity. Further, in the in vivo studies also, all the hematological and general parameters were unaltered by supplementation of Lab 6. Further, we wanted to add a millet bran with this since our institute is working on nutritional biotechnology and food biotechnology. And being a pharmacologist, also, we also wanted to mix a millet bran with this. We use Kodo millet bran, and various research has been now coming up with the use of millet brans for brain functions. So we have generally, as of now, we have seen that from 16S rRNA sequencing, there was a very distinct clustering of all the groups, and we have particularly seen that upon supplementation of this synbiotic, there was a very good colonization of this orange band is of for Labilactobacillus brevis colonization, and again it was shown for the first time that kindling induced Aerococcus clostridium and Enterococcus genera in the kindling model, which was positively correlated with the disease pathophysiology, and our supplementation increased Turicibacter and Lactobacillus. Turicibacter is very much essential for the short chain fatty acid production. So this genera was upregulated by the intervention. So the overall summary of this work is in the epileptic stage, in the colonic system, in the peripheral system, there is a dysbiosis whereby there is a decreased SCFA production, there is a decreased amount of GABA as well, and the short chain fatty acid receptors which are present inside the colon were also downregulated, which induced some kind of peripheral inflammation, and this crosstalk was also linked to the brain functions where there was increase in the oxidative stress, neuroinflammation, and spine density. And this all were ameliorated by the intervention, which increased the GABAergic system, which increased the short chain fatty acid system, and the FFAR pathway was induced to prevent the neuroinflammation in the brain as well as inflammation in the gut system. So this is a summary of my work. I have been working with Professor Kanwalji Chopra, Dr. Kanti Kiran, and Dr. Mahinder Bishnoi. I have three supervisors in my PhD work, and I acknowledge Brick Nabi for funding, Ministry of Science and Technology for his funding, Punjab University and UIPS for my registration and or the for formalities. Thank you. So a small quote. There is a very intricate link between brain and gut. So harbor a healthy gut and cultivate a flourishing mind. Thank you.
Sir, what was the animal you used for this study?
SD right, sir.
SD.
Yes.
Okay. So do you think whatever you are saying that it will be transferred to the human spirit?
Sir, first of all, we have to start somewhere from the preclinical work. So, my work was divided into so much things like we first have to find a rational psychobiotic. Then we wanted to check its safety. Then we wanted to do some preclinical work. Now we are working on the mechanisms of it, how the vagus nerve is linked to this intervention, how other omics things are related to the intervention. First, we are done with all the robust data of preclinical. Then we have collaborations with PGI with different scientists, so we can start some clinical studies with this.
What about the acute and repeated toxicity of it? Will you check that?
Not in patients, sir. These all data is preclinical.
Animal.
Yes, yes, yes.
So what is the data for that?
Sir, as I have shown that from different study we have done the histology of major organs like colon, liver, lungs, and kidneys.
Any dose related?
Yes, yes, yes. So the dose in probiotics, as per the ICMR guidelines, we use different doses. For acute, we use 10 raised to power 12 CFU. For 14 days, then subacute, then acute, we use 10 raised to power 9 CFU. Continuously daily, oral gavage we give to the animals, and we have checked the leakiness of the gut also, that whether this strain is not causing any kind of gut dysbiosis or gut related problems. There were more data in this because of the paucity of slides and time I have not shown in this.
Thank you. Anyone having the question? Okay. Thank you.
Thank you, sir.
Thank you, Dr. Tushar. Request sir to kindly present a token of gratitude. Please come this way. Request all the presenters present in the audience to come on the dais and honor sir. Please. A big round of applause for sir. Please, few of you come here. Thank you very much, sir. Thank you, everyone. We will rejoin in next 5 minutes.
हाँ जी कोई बाहर खड़ जा हाँ भाई ठीक है भाई अच्छा हाँ कौन सी मशीन अच्छा जो फीस करना था सीन क्या पानी वाले कंपनी तो खाएंगे इसलिए सर के बाद नहीं
In the audience, outside the audience, if somebody wants to wail, you can. Welcome back, everyone. We have I have the distinct honor of inviting our distinguished chair, Dr. Pallavi Ahir Rao, who is Professor Pharmaceutical Chemistry, Chandigarh Group of Colleges. May I request ma'am to kindly grace the dais? I now request our first speaker, Dr. Akhil Satyanathan, who is from Vallabhbhai Patel Chest Institute, Delhi, to kindly present.
Okay. Good morning, everyone. Myself, Dr. Akhil Satyanathan from Vallabhbhai Patel Chest Institute, Delhi University. Uh, today, I'll be going to present oral presentation on my topic impact of comorbidities and polypharmacy on adverse drug reactions in elderly and non-elderly COPD patients, a comparative study. COPD is chronic obstructive pulmonary disease. It's a chronic progressive lung disease characterized by chronic inflammation and narrowing of airways, and it is one of the major leading causes of poor health, that is morbidity globally. Uh, and the commonly used COPD drugs are bronchodilators and the drugs which reduces the inflammation. And the drugs are beta 2 agonists, anticholinergics, corticosteroids, methylxanthines, phosphodiesterase inhibitors, mucolytics, and antibiotics such as azithromycin. So these medications are known to cause adverse drug reactions. So the elderly patients, they have higher adverse drug reaction risk due to age-related pharmacokinetic, pharmacodynamic changes, and due to that they are prone for multimorbidity, and uh, and therefore they are prone to take many multiple medications. So this study compares adverse drug reactions between elderly and non-elderly COPD patients along with comorbidities and polypharmacy. So this will help in rationalizing drug therapy in elderly patients and ensure better medication safety. So the aim and objective is to compare adverse drug reactions between elderly and non-elderly COPD patients and assess their links with comorbidities and polypharmacy, and also assess their causality and severity using WHO UMC and Hardwick-Siegel scales. So our study was a prospective observational study, which was done in collaboration with Pharmacology Department and Pulmonary Department in Vallabhbhai Patel Chest Institute, University of Delhi. So we had total 200 patients in elderly group and 200 patients in non-elderly group, and the age criteria for elderly patients was above 60 as per the national policy for elderly persons 2011. So the sampling done was non-purposive sampling, and the patients included were stable cooperative patients above the age of 18 years. Patients who had exacerbated COPD, tuberculosis, pregnant lactating women were excluded. And after giving the patient information sheet, if patient was not able to read, we explained them the pros and cons. And after that, once they agreed, we took their written informed consent. After that, we took their demographic details, clinical data, then medication history. Then we asked the ADRs from ADR checklist, which we prepared, which contained the common ADRs. And any ADRs, if they had, we used to tick. If any ADRs were not in the checklist, we used to put in other section. And after that, we used to assess them for their causality and severity. And then all the ADRs were recorded in the suspected ADR drug reporting form, version 1.4. And we analyzed the data using descriptive statistics, and for categorical data, we used chi-square test. Coming to results, gender-wise distribution, if we see, males were predominant in both the groups, and if we see the patients who are having comorbidities were more reported in elderly group as compared to non-elderly group, and was significant. And number of medications, we can see that polypharmacy, that is taking more than 5 medications, were more in elderly as compared to non-elderly group. And patients who reported at one or more than one ADR or ADR reporting was more in elderly as compared to non-elderly group, and was also found to be significant. And these are the COPD medications which were taken in both the groups. First table, we have COPD medications. Commonly taken medications were oral beta-xanthines, and among inhaled ones, majority of the patients took short-acting beta-2 agonist and anticholinergics, and these were taken for emergency. But for maintenance therapy, most commonly used were inhaled fixed dose combination of long-acting beta-2 agonist and corticosteroids, followed by long-acting beta-2 agonist and anticholinergics, followed by triple therapy. And coming to non-COPD medications, most commonly taken were gastroprotective agents like proton pump inhibitors and potassium competitive acid blockers. And this was given because there was an earlier study which found that oral methylxanthines could cause dyspepsia. This was the reason why more gastroprotective agents were given in COPD patients. And followed by other common non-COPD medications were antihypertensive agents. In that, most commonly were calcium channel blockers, followed by diabetic agents. And all these medications, we can see that it was slightly more in elderly as compared to non-elderly patients. And coming to comorbidity distribution, most commonly reported comorbidity was hypertension, followed by diabetes mellitus, dyslipidemia, ischemic heart disease. And we can see that comorbidities were higher in elderly group as compared to non-elderly group. And when we compared the causality scores, we could found that possible causality was more in more patients. The probable was less. The reduction in probable causality was because the lack of knowledge among clinicians to perform de-challenge or re-challenge test. And if you see the severity of adverse drug reactions, no severe ADRs were reported. Means no patients were having any for ADRs. They didn't undergo intensive care treatment, and the ADRs which were present were majority were mild and also more moderate. And all this and moderate ADRs were more common in both ADRs were more common in moderate ADRs were more common in elderly group, and mild ADRs were more common in non-elderly group. And coming to the adverse drug distributions in both the groups, we can see that most commonly occurring ADR was throat irritation, followed by tremors, insomnia, uh, dryness of mouth, myalgia, hoarseness of voice, and all the majority of the ADRs were more in elderly group as compared to non-elderly group. Coming to summary and conclusion, our study demonstrated that ADR rate was higher among elderly as compared to non-elderly group. This signifies that aging markedly increases the vulnerability to drug toxicity, and also comorbidity and polypharmacy also was more in elderly group, suggesting that multimorbidity and polypharmacy rises steeply with age. So include the limitations which we had was that the COPD patients were compared without a general population comparator group, and reduced use of D-challenge or re-challenge test, and predominantly North Indian study population, and also lack of ADR reporting among patients because of the reluctance. So thus we conclude that age, polypharmacy, and comorbidities collectively heighten susceptibility to ADRs in elderly group of our study. Therefore, we need routine pharmacovigilance, de-prescribing, that is reduction of prescribing inappropriate medications or stopping their doses, and medication review. All this should be implemented to reduce adverse drug reactions in older adults. Thank you. Akhil. Huh.
So your study was on ADR
Ah.
in elderly patient and
Non-elderly,
non-elderly
yes.
patient. So how many patients were there in the study?
Ma'am, total 400, 200 in elderly and 200 in non-elderly.
Okay. And the data like, COPD, you mentioned,
Ah.
like, how many drugs you studied in that?
Ma'am, we studied COPD and non-COPD medications. COPD medications, we studied bronchodilators and anti-inflammatory. Bronchodilators had beta-2 agonist, anticholinergics, methylxanthines, anti-inflammatory, they were given corticosteroids mainly, then mucolytic agents to reduce mucus production, then antibiotics to prevent infection. These were commonly.
So in non-elderly, there were no ADR reported, or if
Eh,
it is there, then it is moderate.
uh,
Okay, as
mild,
compared to elderly one.
mild,
Mild.
on-
Mild
on-
as compared to elderly
huh.
ones. Okay. So audience, do you have any questions? Thank you.
Thank you.
Thank you, Dr. Akhil. We request ma'am to present a token of gratitude to Dr. Akhil. Ma'am, please come forward. Go ahead. Thank you, ma'am. Thank you, Dr. Akhil. So our next presenter is Dr. Sheen Tukra from Jammu.
A very good morning to all the respected delegates present over here. The topic for my today's presentation is cytoprotective potential of Artocarpus heterophyllus lamb seed extract on environmental contaminants, lead, chromium, and thiamethoxam induced renal cell cytotoxicity. The existence of heavy metals and pesticides in environment is a very common phenomena, and this can arise due to a number of factors like agricultural, industrial, minings, and whatnot. But the serious impact of it is on the vital organs like liver and kidney. In order to protect from its harmful effect, people nowadays are using various natural remedies as they are potent, they are easily available, and they have minimal or no effect on the host cell. One such remedy is jackfruit, which is also known as Atrocarpus heterophyllus. It is one of the largest tree-borne fruit, and it is widely cultivated in the Indian subcontinent. A growing body of researchers have verified that it is having a lot of bioactive compounds like phenols, flavonoids, tannins, and ligands. These phytochemicals, they contribute to its antioxidant potential, and because of this antioxidant potential, it is very potent and can be helpful in many chronic diseases, aging related damages, and inflammation. In the similar fashion, we have designed this study to determine the protective effect of Artocarpus heterophyllus seed extract on lead, chromium, and thiamethoxam induced cytotoxicity in renal epithelial cells. Well, the reason of selecting these two heavy metals was because these two heavy metals are found in a large amount in the water bodies of Jammu region. So, first, we collected the seeds of this Atrocarpus heterophyllus, and then we prepared the hydroalcoholic extract of these seeds, and we have done the chemical fingerprinting. And this is the chemical fingerprinting and the chromatogram done by GCMS, and these are the phytochemical identified through it. Next, we have done the in vitro studies for which we have taken the cell line NRK52E. This is a rat epithelial cell lines, and this was procured from NCCS Pune, India. And we have done two tetrazolium dye tests. One is MTT assay, the other one is Risazine assay. So as soon as we received the cell lines, we subcultured it, and after subculturing, when they reach a confluency of 97 to 98%, we seeded them in different wells, and we used our toxicant and the extract together on them. So first, we tried to find the maximum inhibitory concentration, that is IC50 of all these three compounds, that is lead, chromium, and thiamethoxam, and then on our cells, we basically give both of them the IC50 individually and different concentrations of the extract. Okay, so these are the results. The first results are from the for the IC50. So for lead, we use 10 to 160 micromolar concentration, and we got a IC50 of 95.24 micromolar. For chromium, we use 10 to 60 micromolar of concentration, and we got a IC50 of 3.97 micromolar. And for thiamethoxam, we use a concentration of 0.0117 to 0.1875 millimolar, and we got a IC50 of 3.9 millimolar. So after that, we wanted to see the half maximal effective concentration for jackfruit seed extract. So to compare it with the standard, we use gallic acid as a standard. We run different concentration of gallic acid from 1.39 microgram per ml to 357.14 microgram per ml, and we got a EC50 value of 280.89 microgram per ml as depicted by MTTSA, and a EC50 value of 388.19 microgram per ml as depicted by Ricizerine assay. Next, we did it for the Atrocarpus heterophyllus seed extract in the same concentration, 1.39 microgram per ml to 357.14 microgram per ml, and we got a EC50 value of 518.36 microgram per ml as depicted by MTTSA, and 515.07 microgram per ml as depicted by Ricizerine assay. Next, we saw that how these different extract work with different IC50 of all the three individual compounds. First, we use lead. With EC50 of lead, we use different concentration varying from 1.22 microgram per ml to 312.5 microgram per ml, and the value which we got was 1.94 microgram per ml by MTTSA, and 2.09 microgram per ml by Ricizerine assay. This value was able to protect from 50% of the cell death induced by lead. Similarly, for chromium, we used similar concentration, 1.22 microgram per ml to 3132.5 microgram per ml, and the concentration which we got was 2.78 microgram per ml by MTTSA and 3.34 microgram per ml by Ricizerine assay. In the similar way, for thimethoxam, we got the value of 1.89 microgram per ml from MTTSA and 2.06 microgram per ml from Ricizerine assay. At the end, I would like to conclude by saying that the IC50 value indicates that the NRK52E cell lines exhibit the greatest sensitivity to chromium, followed by lead and then by thimethoxam. The EC50 of gallic acid ranged from 280.89 to 388.19 microgram per ml, whereas the EC50 values of Artocarpus heterophyllus seed extract were higher, ranging from 515.07 to 518.36 microgram per ml. Furthermore, the dose of Artocarpus heterophyllus seed extract required to confer cytoprotective effects was lowest for thimethoxam, intermediate for PB, and the highest for chromium. These findings suggest that the phytochemicals present in the seed extract mitigate the oxidative stress induced by toxicant, thereby contributing to the observed protective effects. Thank you so much. These are the references for the study. Thank you, ma'am. Yes, ma'am. Yes. Ma'am, basically, first, let me clarify. This is a small part of my PhD work. Yeah, before that, we have done the phytochemical analysis, chemical fingerprinting. After that, we have seen the total phenol, the total flavonoids, and all the quantitative and the qualitative tests, like free radical scavenging assay. All that thing is being done to see what is the percent, how effective the extract is. After this in vitro studies, we are going to use the extract in vivo studies as well. Yes. Yeah. Yes, sir. And then all present in the extract. I have first slide that we have done the chemical fingerprinting.
That is not clear, no? GCMS, what I see.
Uh,
The interpretation part, your chromatogram is not clear. So, and interpretation you need to really look into, because standardization is important. You must define what is the chemical composition before taking any biological studies. On any extract, you do hydroalcoholic extract. So it is going to extract polar and medium polar compounds. Okay, so why you did GCMS? HPLC would have been better and LCMS would have been better. That is what I noticed. And your extract is not standardized. Before you go for biological activity, it is absolutely important. That is what I thought. And then all these activities are fine. No doubt on that. But gallic acid is such a common compound. It is present in every herbal drug. Whatever you take. Yeah. common polyphenol, which is a component of hydrolyzable tannins, gallitannins, ellagitannins. There are plenty in many medicinal plants, like including this medicinal food plant, jackfruit. No? So you haven't shown any data on flavonoids. These are the compounds which are bioactive, already reported in literature for several activities. So you could have shown that by LCMS, not GCMS, because your chromatogram is not clear. That is what I say. I'm not resolved properly. So please work on that. That will add value to your thesis. Yeah, that is the suggestion from my side rather than a question. Okay, all the best. Good work. Yeah.
Thank you, ma'am.
Wait, Dr. Sheen, please, I'm so sorry. Thank you, Dr. Sheen. We would love to honor you. Request ma'am to do the honor. Please come this side. After you. Thank you. Our next speaker is Dr. Urmi Jain from KEM Mumbai.
Good morning to all. My name is Dr. Urmi Jain, and I'll be representing my research on evaluation of effects of S-adenosyl L-methionine, that is SAMe, in letrozole-induced polycystic ovarian syndrome in Vistar rats. Coming to introduction and prevalence, polycystic ovarian syndrome is a common hormonal condition seen in women of reproductive age. It causes basically hormonal imbalances, irregular periods, excess of androgen levels, which might lead to hirsutism and anovulation. According to WHO 2024 data, basically 8 to 13% of women of reproductive age suffer from PCOS, out of which 70% go undiagnosed. Prevalence of PCOS in Indian women is ranging from 3.7 to 22.5%. Hence, there is a need to look into newer therapies. Coming to the pathophysiology, there are some factors externally which act on the uh, pathophysiology of PCOS, like epigenetic mechanisms, environmental toxicants, stress, and diet. So, focusing on the epigenetic mechanisms, that is DNA hypermethylation and hypomethylation. So, we'll talk about it further. Also, there are some internal factors like insulin resistance, hyperandrogenism, and oxidative stress, which cause increase in the LH levels and decrease in the FSH levels, and also impaired folliculogenesis in the pathophysiology of PCOS. So, why are we talking about this? There are so many therapies, but still there is no ideal approved medical therapy which is being used for PCOS. The current medications like metformin, ocipils, clomiphene citrate, all these therapies are used for different clinical symptoms. Like if the patient presents with obesity, increase in BMI, we start with metformin. If there is infertility, we start with clomiphene citrate. But there is no one drug which is going to completely tackle the complete pathophysiology of PCOS. Also, there are certain side effects of the particular drugs, like metformin may lead to weight change. There can be clomiphene citrate, which can cause multiple pregnancies, endometrial thickening, oral contraceptives, which may lead to increase in the thromboembolic risks. Hence, we need newer therapies. So, coming to our drug, that is S-adenosyl methionine, it's basically a natural sulfur containing compound with a reactive methyl group. So, a meta analysis which was done in 2022 showed that there is global DNA hypomethylation which is happening in women of PCOS. Hence, since S-adenosyl methionine is a methyl donor, we can try and improve that at the molecular level. Also, there is increase in the oxidative stress and inflammation, that is TNF alpha levels in PCOS women. Hence, SAMe, with its mechanism of action of DNA hypermethylation, of antioxidative properties, of anti-inflammatory properties, can tackle the complete pathophysiology of PCOS. Hence, coming to the aim of my study was to evaluate the effects of S-adenosyl L-methionine in letrozole-induced PCOS in Vistar rats. Objective was to evaluate the efficacy on hormonal parameters, that is LH, FSH, testosterone levels, to look at the mechanism of SAMe with the help of GSH assay, to evaluate the efficacy in histopathological parameters, that is the antral follicles and the corpus luteums, and the metabolic changes, that is blood glucose, triglycerides, and cholesterol levels. Coming to the materials and methods, after the IAEC permission, 36 female Vistar rats of 4 to 6 weeks were obtained. We used letrozole to induce PCOS, so that was 1 milligram per kg, and the study drug was SAMe, lower dose at 100 milligram per kg and the higher dose at 200 milligrams per kg. Positive control, we used metformin with 300 milligram per kg per day. It was a 21-day model. The letrozole and the respective metformin or SAMe, depending on the group of the animals, was given to them. And at day 21, blood collection was done. The animals were sacrificed for histopathological examination. So these were the 6 groups, 6 animals each group. Normal control were given saline, vehicle control were given 1% CMC, disease control with letrozole, positive control with letrozole plus metformin, study drug with letrozole plus SAMe lower dose, that is 100 milligrams, and a higher dose was with 200 milligrams per kg per day. So coming to the observation and results, we can see that the effect of SAMe on luteinizing hormone, we can see that the lower dose as well as the higher dose are showing significant results as compared to the disease control group. There was no significant change seen on the FSH levels comparatively. If we see the testosterone levels, we can see the higher dose have shown significant effect as compared to the disease control group. Also, if we see the GSH assay, we can see that there has been a significant increase in the level of glutathione with the higher dose. Coming to histopathology, that is number of follicles. So antral follicles and corpus luteum are one of the important follicles which needs to be seen in PCOS. In PCOS, basically what happens is there has been an increase in the number of antral follicles as there is anovulation. So we can see with the help of higher dose of SAMe, we can see that there has been a significant decrease in the number of antral follicles. Similarly, there has been a significant increase in the number of corpus luteum, indicating there has been ovulation. That is, the corpus luteum part is also in comparison to the metformin group, that there has been a significant change with comparison to the metformin group. So these are the histopathological slides where we can see the number of antral follicles have increased in the disease control group and significantly decreased in the SAMe higher dose. So these were the results for the biochemical markers, that is the cholesterol and triglyceride levels. Again, the higher dose of SAMe has shown significant decrease in both the levels of cholesterol and triglycerides. And similar effects on glucose, that higher dose has shown the effect on glucose. Coming to the conclusion, SAMe has significantly reduced LH, serum testosterone, glucose, cholesterol, and triglyceride levels, suggesting an improvement in the hormonal as well as the metabolic profile. A reduction in the antral follicles prove that there has been an improvement in ovarian morphology. There has been an increase in the corpus lutea, that is basically telling us an improvement in ovulation. SAMe significantly elevated GSH levels, hence the antioxidative property is working. Uh, However, SAMe did not produce any significant changes in the FSH levels, but still overall I would like to conclude that SAMe, particularly at higher doses, have an add-on therapeutic potential in mitigating the hormonal, metabolic, ovulatory and oxidative disturbances which are associated with PCOS. So we didn't use metformin plus SAMe combination group because they might complement the mechanisms for each other. That was one of the limitations for my study. We are already in process of doing the 5-methyl cytosine levels and the insulin levels for checking out the insulin resistance, which was done in the PCOS. And I would like to thank Diamond Jubilee, ICMR, and Research Society for their funding. And I would also like to thank my team similarly. These are the references for my study. Thank you. So, ma'am, like I said in my presentation, we are moving towards antioxidative, anti-inflammatory properties. But SAMe has shown an additional mechanism, that is the DNA hypermethylation. Basically, when there is global DNA hypermethylation, which has been proven and seen in PCOS patients. So if we try to mitigate that, it might actually help in the clinical differences clinical features of the patients. So that was one of the reasons, because there are a lot of other antioxidants which are already used, but because this has this one additional property, we can say that this might help in mitigating the clinical features. Huh. Metformin. No, ma'am, we have not given combination. It's yes, ma'am, we have compared that. We have compared that as well, but there was not that was not significantly different. So it is comparable with metformin. Yes. So all the biochemical parameters and the hormonal parameters are comparable, but while we see the histopathology, we can see that there has been an increase in ovulation. So that is how I am trying to place it where it can actually take in consideration all the clinical improvement as well as the anovulation thing. Yes, ma'am. Yes. Thank you, ma'am.
Thank you, Dr. Urmi. Now I would like to facilitate Dr. Urmi. I request the chair, please facilitate.
Our next speaker is Dr. Orko Bhattacharya. So it will take us few minutes to upload your presentation. We need to conclude this session at this point. Dr. Arko, we will be rescheduling your presentation post this session. So we would request all the speakers present in the audience to come over the stage and honor ma'am. Those who are present. Let me check. So Dr. Sheen, you can come. Thank you, ma'am. Present the results yourself. We will go for tea break and we will rejoin at 11:20. Thank you. Presentation could not be uploaded in to us. Dr. Arko, request you to please come back. Your presentation is uploaded. No, he's there outside now. यही है बेटा कहाँ है अच्छा it's uploaded. हाँ, this is not. Maybe there, what ma'am will have to have. This is what I- No, no, no. हमारे ना यहाँ नेट की हम प्रॉब्लम है we're facing a lot of net issues. There's a major net issue in our बैटरी नहीं है नहीं आपको पॉइंट चाहिए ना पॉइंट ये चलता है ये चलता है ना ठीक है ओके स्लाइड आगे you need to call your team yeah there just a minute yeah yeah
Hello. Hello. Yeah. So, good morning, everyone. So today I will be presenting a small part of my work which I am doing at Brick Nabi. So, the title of the work is Symbiotic Bacteria Consortium Attenuates Lipid Dysregulation and Inflammation in
metabolic associated stereotypic liver disease via gut liver axis modulation. So, at first, it's just a brief definition of obesity. It's just obesity is abnormal accumulation or enhanced accumulation of fat all across the body. And according to World Health Organization, the BMI index over 30 is termed as obese. So, right now, it is a silent killer, as the majority of the Indian population, due to Western diet and sedentary lifestyle, is having is overweight. So, according to this graph, which was uh, currently published in Lancet, this study is showing that by the year 2050, majority of population will be obese. So in our lab, Healthy Gut Lab in Nabi, we are working on probiotics and prebiotics. So we have, I come from agricultural institute. So we tried to make a valorized Kodo millet bran where we get rid of the fat fraction and the polyphenol fraction from that. So after valorization, we thought, can it be used as a prebiotic, or can the bacteria can utilize it in the gut? And yes, we have already published some studies which says that Kodo millet bran can is being uh, giving good um, health benefits, and uh, papers have been published. So again, this was a paper, and again, coming to the bacterial consortia, we are using two strains of Bifidobacterium and two strains of Lactobacillus. They have also shown some antioxidative property and they and anti-inflammatory property. So going to these are the recent paper. One paper in the food bioscience says that this four strains, they are safe to be used according to the OECD guidelines for acute, subacute, and subchronic toxicities. So going to the next slide. So the first part of the study focuses on how this symbiotic blend, which consists of the Kodo millet bran and the two strains of Lactobacillus and two strains of Bifidobacterium, modulates the gut. So first thing we wanted to see whether the this symbiotic uh, is growing with this Kodo millet bran. So we saw some difference in the titable acidity, which was giving like similar to that of glucose, which was taken as a positive control. And again, there was enhanced total SCFA in the symbiotic group. And coming to the bacteriodata and bacillota and bacteriodata ratio, and we also saw some positive modulation, which was showing that it wasn't increasing uh, dysbiotic situation. And again, coming to the PCA plot, we were seeing there was a negative correlation of Clostridium, Ruminicoccus, and Lacinospiracy from the symbiotic group, saying that the symbiotic groups were promoting good bacteria in the gut rather than the bad bacteria. So coming to the conclusion, the bacterial blend and the symbiotic blend promote the growth of beneficial bacteria and SCFA production. So coming to the second part of the study, we tried to look into how the bacterial blend was acting on the gut, because whenever we are consuming any food, it will be coming to the gut, and from there it will be digested by the gut microbiome. So the gut, for the simulation of the gut, we used CACO2, which is a epithelial cell line from the intestine. So first we wanted to see how it is modulating the TER, which is a trans epithelial resistance. So we just wanted to correlate it with the like leaky gut. So we saw that, and we also made one model with palmitic acid and LPS, which just resonates the endotoxemia during the dysbiosis. So here we had I have only showed to two groups, which palmitic acid LPS and bacteria given with the palmitic acid LPS. So here we saw after the administration of palmitic acid LPS to the CACO2 cell line, there was a decrease in the tear, and which was again prevented by the bacterial administration. So this is again fixed dextran permeability, which also showed the similar trend. Again, coming to the western of the tight junction and the inflammatory markers such as beta alpha, MID88, TLR4. We also saw some positive modulation with the bacterial blend. And I also kept a group with the saroglitazar, which is a ICMR approved drug for obesity. So again, coming to the tight junctions, we have evaluated claudin and ocludin. And again, we have also seen the expression of zona ocludin, which is also a tight junction protein. Again, we have also seen the expression of the alpha catenin. I think it's shown in the red. I think you can see it in the projector. So again, going to the conclusion, the bacterial blend preserves the intestinal barrier integrity in CACO2 monolayer by reducing permeability and ROS level, enhancing the tight junction protein expression, restoring the TO values under palmitic acid LPS induced stress. So again, coming to the second set of the experiment, we did the co-culture of CACO2 with the liver cell line, which is a HEPG2, to see how it is the gut, what is the correlation between the gut and the liver. So after giving the treatment of the palmitic acid LPS and bacteria with the palmitic acid LPS, we saw some positive modulation in the fat deposition. So with the bacteria given with the palmitic acid LPS, we saw the lesser fat deposition, which were seen by the green fluorescence by the body P staining. Again, coming to the ROS production, which is reactive oxygen species production, we also saw that the bacterial blend, they were quenching out the reactive oxygen species. So again, coming to the gene expression of different genes of lipid metabolism, lipid uptake and transport, we also saw that the bacteria and palmitic acid LPS, they uh, uh, they showed similar effect of the saroglitazar, which is a dual agonist of PPR gamma and alpha. So coming to the insulin resistance, the bacterial blend also it also given protected against the insulin resistance. Again, it also enhanced the glucose uptake and it decreased the cellular palmitic acid accumulation. So coming to the second set, the conclusion coming to the bacterial blend prevented liquid accumulation in HG2 cells, which is the basolateral layer, by reducing the insulin resistance and restoring lipid metabolism under palmitic acid LPS induced stress. So coming to the second part of the study, which is the in vivo, we just wanted to see how the bacterial blend is working against high fat diet induced obesity in C57BL6J mice. So here we had the six groups, which is a normal diet given animals, high fat diet, symbiotic saroglitazar per se, and symbiotic in a high fat diet, saroglitazar with a high fat diet, and they were fed for the 12 weeks, which is for three 3 months. So after the 3 months, we sacrificed the mice and we looked into various parameter which I am going to discuss now. So again, for the, uh, there was a significant amount of weight gain which can be seen in the panel. So a significant amount of the weight gain with the high fat diet, which was again prevented with the saroglitazar and with the symbiotic, which was it was given. And again with the body fat, this percentage body fat and the lean weight was estimated by the DEXA. So here we can see that these two group, this is the symbiotic and this one the saroglitazar are given with the high fat diet. They have the significant reduction in percentage body fat, and there was non-significant alteration in the lean weight. So coming to the insulin resistance and glucose homeostasis parameters, we did check the quick index and the HOMA IR, and we saw the similar trend with of the control animal. So after that, we tried to get into what is the trend with the histology of the white adipose tissue. So here we did the histology, H&E staining of the white adipose tissue, and we tried to evaluate the size of the adipocytes, and we saw that in the high fat diet there was like a curve, bigger curve for the adipocyte size distribution for the high fat diet, but the other interventions, it was quite uh, similar to that of control. So symbiotic blend prevented high fat diet induced weight gain, fat deposition and insulin sensitivity in C57BL6J mice. And again, coming to the last part, here we have evaluated the symbiotic blend in hepatomodulation. So we know that with the high fat diet, there is the lipid accumulation in the liver. So in the like like the organ morphology after the 3 months of the given high fat diet, there was a indication like the liver was pale, other in the from the other groups. Again, coming to the tissue morphology, we have seen there was a vacuolation in the high-fat diet given tissue, and the other tissues were not significantly altered, signifying that the symbiotic blend was preventing the vacuolation in the liver. And coming to the last part, which is the label-free proteomics, we tried to understand how the whole liver proteome was altered in this symbiotic treated group, and we compared it with the high fat group, and we saw that uh, the fatty acid transport, beta oxidation, gluconeogenesis, carbohydrate metabolism, and various other pathways were altered. So, coming to the conclusion, the symbiotic blend effectively restores liver morphology, improves tissue integrity, and beneficially modulate hepatic proteome pathways disrupted by the high fat diet. So this is a small like graphical abstract of what it is doing. Like the symbiotic blend, it is like protecting the gut barrier integrity, and from where there is a very less leakage of the toxins into the liver, which are being transported by the portal vein. Whereas in the high fat diet only given animal, there is a leaky gut and there is a endotoxemia, and there are the toxins which are going to the liver, and there is more fat which is going to the liver, and which is causing the fatty liver. And again, I want to thank my group, Healthy Gut Research Group, from where I come from, and I want to acknowledge Break Nabi for giving me the infrastructure. I want to also thank RCB for giving me the registration, and CSR for the fellowship. Thank you, everyone. Um,
Presentation. You have done quite a lot of work on gut microbiota.
Yes, ma'am.
I have two questions for you.
Sure, ma'am.
Yes, I say the same biotic you have used.
Yeah.
The photobillet,
A codomillet bran and bacteria. Yeah.
the probiotic and photobillet, the food.
Yeah.
Directly to the same biotic or have you done any comparative study first?
Uh, like for only the codomillet fraction, the work has been already published. Like the paper I showed before, like this one in the food and function one. Uh, Similar study has been done. Yeah, yeah. So we have already published. My senior has published this work. They have also shown that there is a protective effect of this codomillet brand whenever we are taking the. It is more of a fiber fraction of the codomillet. Yeah, yeah, yeah. Mhm. Yeah, that is also related. We have used the same model. Same model. Yeah.
The second question is regarding you said that um, your same biotic is
Mhm.
also giving opportunity to our skin with fish.
Yeah.
So that means that it will be helpful in fatty food,
Yeah.
especially fat.
Yeah, it will be because we have used the yeah, it will be. Nash, its name has changed to MSLD only. Yeah, we have this model is 60% high fat diet, and for like 12 weeks, it is a standard model for MSLD. So that's what we are looking into. Yeah, yeah. The study is going on. Like this is just one fourth of the data. So we had to because of the time constraints, we had to remove a lot. So yes.
Is there any symbiotic
Mhm.
preparation condition of the market?
Yeah, there are like right now at this point of time the market is flooded with it. Like there is one symbiotic. Yes, ma'am. Yes, ma'am. We right now the formulations which are in the market, they use the bacterial strains from the out foreign origin. So as we know that the strains are also gut compatible. It should be gut compatible. Like in our Indian population, we have a different kind of gut other than the foreign. So if the strain is been isolated from a foreigner, so the strain is having like it needs to have a ecology like a different environment it will be growing on. So there can be like a probability it might not colonize that good in the human gut, like in the Indian gut. So the four strains we are using, they are indigenously isolated strains, and like we have characterized it, and we have using it for like different purposes, and two like one of the patents are already been published for this bifidobacterium and the DSS given colitis. So we are just trying to come up with a formulation right now, uh, just for a human, just for the Indian gut. Mhm. Yeah. 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 Yes, ma'am. This. Mhm. Yeah. Mhm. Uh, yeah, absolutely. But the thing is, we are valorizing it. Like we are getting. Yeah, sure, sure, sure. Yeah, sure, sure, sure. Yeah, and that's it, ma'am. Because this right currently the change in the diet and everything, it is the mainly causing, rather than the sedentary lifestyle. I will say that shifting to the Western diet, that that is a major issue. Like before, like 30-40 years, people used to have the ragi, bajra, and everything. They used to have curd, but now the lifestyle. Again, it has been changed. Yeah, everywhere. Yeah, even millet cookies, everything. Okay. Okay.
Thank you, Dr. Arko.
Yes, yes. I have a question regarding composition. The technology is still having what is the ratio of bacteria versus fungi?
So that is very important. Number one. And there will be interaction before you really administer, or is it freshly prepared blend? That makes lot of actually sense here and need to optimize. So have you done something on that?
We have done. So coming to your first question, so what is the ratio? Like the bacteria we are giving, like for the animal studies, it is 0.25 OD per bacteria, which is just coming up to 1 OD for the total one. And just that was for the in vitro, and 1 OD of each bacteria for the in vivo. And coming to the second question, yes, we are preparing it like we are giving the codomillet in the diet, which is the 10% of the diet will be having the codomillet brand, and we are currently oral gavaging the bacteria. So, and yes, according like I want to share something. So we have the seed store of the codo millet and everything. We see there is a degradation of phytoconstituents over a year. So we see a lot of iron. So yeah, we are using the fresh stock for everything.
Yeah, because that has to be. Otherwise, they will also interact bacteria before you really start your study. Yeah. So and your whatever results will be completely different. So that has to be taken care.
They do like lab.
Yeah.
So they will be going into the dormant stage. So after that, you can just mix the bacteria with the bran. It will be a powder, and it can be used whenever you want to use. You just put it in water.
Okay. And have you done any gene expression studies for mechanistic aspect in the fatty liver case? Like you said there,
Proteome.
it has been done. Okay, I could not follow that. So anyway, and another thing that you have not shown any biochemical parameter, whether they were
Sir, there are
reduced.
a lot of biochemical parameter. I had to get rid of them due to the time constraint. Yeah.
But is it a positive trend going down like your LDL, total cholesterol, triglycerides, everything you did, right? Yeah. Mm.
Mhm. Yeah, cholesterol,
Okay.
yeah, triglycerides.
Okay, good. Very good work. All the best.
Dr. Bhattacharya? Thank you, ma'am. Thank you, Dr. Bhatta sir. Thank you so much. Okay, so we will join back at 11:20 for the next session. Thank you. Ma'am, these are yours. Do we have any presenters for 11:20 session in the audience? We would like. Ma'am, you are Dr. Meenakshi. Okay. Who else? Ma'am, your presentation has been uploaded? Okay. Anybody else? Ma'am, we need your presentation. Is Dr. Deepika in the audience?
Good morning, everyone, to the next session of IPSCON 2025 of oral presentation. Now, I would like to invite Dr. Deepak B. Salonke from Department of Medicinal Chemistry, Naipur, Mohali. Sir, please ascend the dais. Thank you. Now we have the first speaker of oral presentation, Dr. Deepika Saraswat from Defense Institute of Physiology and Allied Sciences, Delhi, to kindly present her oral presentation.
A very good morning to all. And good morning, sir, Dr. Deepak ji. Uh, Fortunately, I'll be presenting the work which we have given the cars 11 to Naipur Mahali only. So it's my privilege that I'll be presenting your data in front of you. So, very good morning to all of you. I think all our students, mostly are the students. So, firstly, I would like to say that I came from the prestigious institute Defense R&D Organization, that is DRDO, and one of its lab, DIPAS, Defense Institute of Physiology and Allied Sciences. Basically, in DIPAS, we are carrying out the physiological work, physiology related to the high altitudes and all the extreme environmental conditions in which our soldiers are posted, and how they feel, and what all physiological implications they have to face in the extreme terrains. So on those things, we people, the scientists, we are working over there. One of my colleague, Dr. Richa Rathore, she has already delivered lecture yesterday, day before yesterday. So, and another colleague, Dr. Rajkumar Tulaswani, he also came from the particular institute. So we three are here in order to enlighten our youngsters about DRDO. And if you people are interested, you can also come to this institutes for your work and for your research ideas. So today I'll be presenting the talk on one pharmacological intervention that we have thought of for the soldiers. And the toxicity, as you know, the acute and repeated dose toxicity is very much essential for any drug to come to the market. So before that, we have to check the toxicity aspect of it, and that I'll be covering in my lecture. Just now I said about the high altitude. So how many of you know what is altitude? Yes, elevation, vertical elevation from the sea level, that is known as altitude. So based on the altitude height, we can categorize this altitude in four different categories: low altitude, below 1500 meters, then from 3500 to 5500, high altitude, and then above that is extreme high altitude. So the soldiers, when they ascend rapidly to these altitudes, they face various physiological alterations, and because of that later develop into the pathophysiologies. In this slide, as you can see here, basically what is happening, they feel low, energetic level low, and that is happening in the mitochondria. So mitochondria dysfunction is the main thing for their energy alterations. So our group is basically looking for upliftment of that activity so that they can perform, they optimize their activity in that extreme terrains. These are all the physiological implications what they used to feel at that particular, that the cerebral blood flow will be decreased. Because of that, there is some focus attention problems. Then hyperventilation as a mean of adaptation to that high altitude. Pulmonary artery pressure will be increased. Cardiac output, heart rate, all these will be increased because more of the blood is required for performing the basic essential requirement of oxygen to the different parts of the body. And likewise, other physiological alterations are also there. And in the right side of it, I'm showing that the mitochondria, because all these complexes, they undergo somewhat malfunctioning because of that lower functioning of these complexes, as a result of which more of ROS formation, most of ROS, reactive oxygen species in the blood. So because of that, other physiological implications, these are all the things which we noticed at the cellular level. Enzymatic action will be altered. So like that, all those things will happen. So what is our aim? Our aim is to maintain the normal physiological conditions at that particular extreme terrains. Because of this changes in the physiological changes, this will be implicated in the form of acute mountain sickness, where you will be feeling nauseatic, confusion, you can't walk in the straight line, like that. All those, that is known as acute mountain sickness. If you won't treat this at that particular point, then it will be culminated into the more severe pathophysiologies, like that of the high altitude pulmonary edema. Pulmonary, lung, and lung will be filled up with the water type of thing. So that is pulmonary edema. So what will happen because of that? You will not get the sufficient amount of oxygen because respiration will be altered. And if not treated at that time also, then it will be again converted into the high altitude cerebral edema. So brain will also get that water, and then at that particular thing, there is no chance of rescuing the soldier from that particular pathophysiology. So the only treatment is to bring them down, lower altitude. Now, because of it, because in order to meet the decline in the oxygen concentration in the blood, the heart is the main muscular organ which has to continuously, rhythmically, it has to pump the blood to the lungs so as to meet the deficit demand of oxygen in the body. So, because of it, because of the extra, but if I put extra work on you, what will you will feel fatigue? You will not working means you will not feel like work the way you want to work. Okay, so heart also is doing extra work in extreme environment. So hypertrophy will develop in that heart, right ventricular heart, because it has to pump more blood towards the pulmonary beds, vascularization. So what happens? Some dilate in the initial stage, that is adaptation or the acclimatization to the changed environment. But if you continues that one, then that will develop into the some pathophysiology, that is known as dilatory right ventricular hypertrophy. I will not go deep into that, but the only thing to understand here is, in the normal condition, our body tries to acclimatize in the change extreme environment. That is okay, that is known as, if it is persisting for the long time, that is known as adaptation. If it is for a small duration, that is known as acclimatization. If our body is acclimatized, well, fine, the person is known as acclimatized. If not, then it has to go for some pathophysiological thing, and there is no intervention available for directly for right ventricular hypertrophy. Other things are there, like for blood pressure you have the medicine, for calcium channel blockers other medicines are there. So but these are all um, in a distributed form. So that is the why I am telling all these things. This is the need for forming some formulation that will affect or that will target that particular right ventricular hypertrophy. Now, for this reason, we have developed this drug, which is the combination of nanocurcumin, and PQQ, which is a redox cofactor which will take part in metabolic activities. Metabolic, it will fasten or it will improvise the activity of your mitochondria, as well as another good thing is about PQQ is it will do the mitochondrial biogenesis, means you will get more number of mitochondria. Definitely your ATP production will be increased in the body. So that will suffice the purpose. And curcumin, because of its lower availability in the body, so it has to be converted in such a form that it will be distributed equally and it will distribute more, so that we will get the benefit of the curcumin. For that reason it is converted into the nanotized form. Okay, so this is our formulation and these are all the benefits of it. I will not go in deep into it because I have the time constraint. And these are the different 10 pictures of our formulation. And for this, DIPAS, DRDO has got the patent, Indian patent also. And these are the beautiful publications out of it. And now, if if we want to produce any drug, then what is required for it? It should not be toxic. It should be safe for the intake. Though we all know that curcumin is a pigment which is very safe, and it is the recipe of every kitchen. So why there is no question of toxicity? But this is not the thing. It is combined with some another molecule PQQ, which is also very safe to use. In combination, we never know whether it is toxic or not. So documentation is required before giving it to or prescribing it to some person or the human being. So for that, we have given this task to Naipar Mohali, and they have conducted this preclinical toxicological evaluation based on the OECD guidelines. So for that, two type of things: acute toxicity, that is according to the 407, and one is OECD guidelines 423. So these two guidelines were followed because DCGI will not entertain your drug, they will not believe your data unless it is from some good lab practices. And Naipur Mohali was GLP certified lab. So we have given our formulation to them and they have conducted these experiments, toxicological detail experiments, and they have submitted the report to us. Now, based now these are all the results. What parameters? I'll just explain that. Yeah. So for that single dose, they have divided the experiments into two steps, and they have chosen the dose as 2000 mg per kg body weight. For 14 days, they have observed the rat, and after that, they have overdosed the anesthesia with that. Then after that, they have collected the blood and organ tissues for their examination. And for the reported dose toxicity, they have divided this into four groups, and one is control, and another one is 250 mg per kg body weight, and 500 and 1000 mg per kg body weight. After they have made the observations till 28 days, and after that, with the overdose, they have anesthetized the rat and collected the blood and the tissues for further examination. And for the methods, they have chosen the locomotor activity assessment, physiological data, in which they have selected the body weight, mortality, clinical signs, gross necroscopy and ophthalmoscopic analysis, food and water intake, absolute and relative organ weight, hematological and biochemical parameters, and the histopathology wherever they feel like that is required.
Dr. Deepika, your time is 1 minute last.
1 minute only, sir. Okay, then I will just skip the slides. So these are
It's
body
already
weight.
over.
I'll just, these are the body weights. As you can see here, there is no change between the drug and the control body weights in the single and the repeated doses. Even for the locomotor activity, it was found that they are on par, almost on par with the control animals. Even for the mortality rate, as you can see, 000 figures. No mortality was observed either in the single or the repeated dose. Thalmoscopic also, nothing was visible that that the drug in combination is hampering their vision. And for the absolute organ, absolute means the total body organ weight. So that also it was not found much change. Even for the relative organ weight is in comparison to that of the body weight. So that is also not found to be much difference. Hematological profile was also very good. It was on par with the control animals. And for the biochemical profile also, as we can see, what they have reported that nothing was, few things were observed, but nothing much change. And the same thing was observed with the histopathophysiology. Nothing change was observed. Means the animals are as good as that of the control animals. So this is in nutshell the salient findings of our formulation. In an increase in the locomotor activity in the low dose treatment was observed both in male and female animals. In male animals, how dose treated, some WBC count and other things were found to be increased, but because of the this will not affect their when we see in the dose response way. And in the male rats, some prostate and seminal vesicles have shown significant increase, but in absolute organ weight and in relative organ weight in comparison to the control arm. But however, these findings do not corroborate with the histological analysis, because once they found that some increase was there, then they have checked with the histophysiological examination, but that was not found. So here we conclude that the changes in the toxicological parameters were not dose dependent in the nature in either of the sex, and most of the changes were in the category of background lesions. So they concluded that this drug is safe. So now we are progressing further with the clinical trials, that is with the humans. So we have already submitted the project, and we are in progress. Thank you all for your kind attention. Thank you.
Okay. Thank you, Dr. Deepika. I think it was an interesting like contribution from DRDO. And you all know that there are two DRDO labs in Chandigarh. Which ones?
Yes. Tell anyone.
Two DRDO labs in Chandigarh. Yes, yes. Yeah. So, and one more? EBRL. In fact, one of the I think what is Bihar. Bihar is one of the I think main I think head office is in also in Bihar. So I think because you talked about high altitude labs and all, so I think DRDO is going good contribution. So I think it was interesting to see that curcumin and PQQ like effect. So any questions from the audience? One question at least. Okay, I have, ma'am, one question.
Yes, please.
Because I'm evaluating it.
Yes.
So, like, I wanted to know the PQQs, like, what was the dose? Because you have shown the toxicological studies, but what about the in vitro or in vivo studies? Like,
We have
of
the
that
published. I have not mentioned here
exact, like, what is the mechanism of action of PQQ?
PQQ is a mitochondrial biogenator as well as mitochondrial dysfunction. So there the functionality will be improved. So it is all these all together. They are working on the oxidoreductases mechanism, basically on the mitochondria, all that pathway, and then inflammatory pathway, NF kappa B, AP1, all those pathways they will it will cover. And the good thing is that mitochondrial based things. And another one, curcumin, that is known for anti-inflammatory and this thing. And very important is that this is the wonderful antioxidant molecule.
Mostly you meant care of the inflammation, the edema
Inflammation,
taken care.
they will generate the mitochondria if required. They will improve the function of the mitochondria if required. They will take care of anti-apoptotic molecules. So they will take care, they will not allow the apoptosis to happen. And if at all it is happened, curcumin is there to take care of inflammation. So like that, it was thought of the formation of this formulation is based on specifically for the needs of the soldiers at the high altitudes, because at the high altitudes we cannot give the drug we will give only when the disease will be there, but the pathophysiology is because they are the normal people, and it has to be with the normal physiology, and they have to perform best at that extreme environment. So based on that, this formulation was thought of. It is a preventive rather than of curative. Even if it is curative, we have checked this in the animal model. In that also it will take care of to some extent RVH. It will not allow the RVH to happen. RVH,
Okay.
when I am telling it is pathophysiological RVH, that is dilatory RVH. RVH
Okay,
is
I think
required for
I think that is
education.
quite interesting because you can see that because it is a prophylactic, so we need to make sure that at a very high dose also it is not toxic. So
It is not
they
toxic.
have done that. So thank you, ma'am, for interesting talk.
Thank you very much. Thank you for listening patiently.
Ma'am, please stay here.
So we have our second presentation.
Sir, we want to facilitate. Sir, I request our chairperson to kindly facilitate Dr. Deepika. Ma'am, please. Yes, ma'am. Our next presenter is Dr. Meenakshi from Government Medical College and Hospital, Chandigarh. Dr. Meenakshi.
Good morning, everyone. Good morning, sir. Myself, Dr. Meenakshi Raju, and I'm from GMCH Chandigarh. So today I'm going to present the oral presentation, which is titled as Evaluating Risk of Drug Reaction with Eosinophilia and Systemic Symptoms with Common Analgesics, which is a FDA Adverse Event Reporting System based disproportionality analysis. So starting with the introduction part, drug reaction with eosinophilia and systemic symptoms, that is DRESS. It is a rare, severe hypersensitivity reaction with rash, fever, eosinophilia, and multi-organ damage. And it is often caused by many anticonvulsants like carbamazepine, phenytoin, and phenobarbital. And antibiotics most commonly associated with the DRESS syndrome is like amoxicillin, piperacillin, cotrimoxazole, vancomycin, etc. But in the recent past, several cases of non-steroidal anti-inflammatory drugs has been evolved, from which ibuprofen, diclofenac, acetaminophen, and mefenamic acid. These were the main drugs which have shown the strongest potential of adverse drug events. And these drugs may induce the DRESS syndrome via immune or metabolic mechanisms in predisposed patients. And many new emerging molecular evidence links the DRESS syndrome with the genetic susceptibility. Like many HLA haplotypes has been found which are linked to the DRESS syndrome, drug metabolic variability, and immune reactivation, and many viral reactivation during the DRESS course. They have offering the deeper insight into the mechanisms which are underlying the DRESS, and not only one mechanism. These three should be involved to cause the DRESS syndrome. Uh, so identifying the rare adverse drug reactions like DRESS, it requires the post-marketing surveillance. So disproportionality analysis, which is a validated quantitative method to detect the safety signals or adverse events in the pharmacovigilance and drug safety in large databases like FAIRS, that is FDA Adverse Event Reporting System. And this proportionality analysis, it is a tool which is very quick and inexpensive to use, with which we can correlate the risk of that particular drug with the adverse event. So the present study aimed to evaluate the risk of DRESS associated with commonly used analgesics using a FAIRS-based disproportionality analysis and promoting the safer prescribing and early detection. So starting with the methodology, first of all, study framework and data collection source. The present study adopted a retrospective or previously recorded databases retrospective pharmacovigilance signal detection and evaluation approach, and data were drawn from the FDA Adverse Event Reporting System covering quarter 4 2003 to quarter 2 2025, and each quarter comprises 3 months of period. Then case screening and data retrieval. Data were extracted using the Open Vigil 2.1 software with the DRESS as adverse event of interest. And the following non-steroidal anti-inflammatory drugs were assessed, like mefenamic acid, piroxicam, meloxicam, ibuprofen, diclofenac, naproxen, acetaminophen, and aceclofenac. Mainly these 8 drugs were followed for DRESS. And medical dictionary for regulatory activities, that is MADRA, lower level terms were used for the precise case identification. It is the internationally terminology based dictionary which we used in this case detection, and only reports where the drugs were the primary suspect were included. And the systematic steps which were applied to refine the data set. First one was the initial data export. So reports of DRESS linked to non-steroidal anti-inflammatory drugs were exported from the Open Vigil 2.1 into the Excel sheet. And secondly, then identification of the duplicates by reviewing the key columns like case ID, date, age of the patient, gender, drug name and event, etc. And mainly the case ID used as the unique identifier for duplicate detection. Thirdly, third step was automated deduplication. In Excel sheet there was already inbuilt remove duplicates tool was present, which was applied to identify the case ID column and to eliminate the all exact duplicates. Then signal detection using the disproportionality analysis. So to establish the association between the NSAIDs and DRESS was evaluated by the disproportionality measures like PRR, which is proportional reporting ratio, and the reporting odds ratio, for which we have made the 2:2 contingency table. And these are the formulas for PRR and ROR, where capital D and E means NSAIDs were given after which DRESS syndrome occurred, and small d and e was where no NSAIDs were exposed but still patients developed the DRESS syndrome, and capital D and E where NSAIDs were given but no DRESS syndrome occur in the patients, and the lastly small d and E in the contingency table where no NSAID was exposed to patient and there was also no any case of DRESS syndrome. And for all this, we have used the Evans criteria to identify significant signal for the DRESS. And the Evans criteria was if there are reported cases of more than 2, chi-squared statistic value was more than 4, and PRR, proportional reporting ratio, was more than 2. So these parameters provide a robust approach to determine whether an association between a drug and an adverse event is causal rather than the coincidental. And for the ethics part, as FAIR's database is publicly accessible and do not contain any personal identifiers, therefore no formal ethics approval was required for this study. Coming to the results part, as we can see here, from the NSAIDs, mefenamic acid, piroxicam, meloxicam, and ibuprofen, if you see the number of DRESS reports were only 3 for the mefenamic acid out of total. If you plus the number of DRESS report 3 and DRESS reports for other drugs, that is, then it will be total 17,017. So only 3 cases of DRESS particularly linked with the mefenamic acid, and the PRR value for that was calculated as 17.91, and the chi-square value was 32. And if we see the Evans criteria for mefenamic acid, again the number of cases of reported cases of DRESS is more than 2, that is 3, and chi-squared value is more than 4, that is 32.50, and PRR. So mefenamic acid is strongly, according to the Evans criteria, gives the statistically significant association with the DRESS syndrome. And again for the piroxicam, meloxicam and ibuprofen, if you see the Evans criteria, these 4 drugs, they were strongly associated with the DRESS syndrome. So again, mefenamic acid, as we said, as I already said, reported for only three cases out of 17,017 drugs, and piroxicam only 17 cases out of total 17,046. But still, these drugs showed the strong pharmacovigilance signals for the DRESS despite their limited reports, which suggest a potential risk of severe hypersensitivity reactions with both the drugs. So, clinicians should be alert for the early signs of DRESS. As also, Indian Pharmacopoeia Commission in 30th November 2023 has issued an advisory for the mefenamic acid, which is also said that it's linked with the DRESS syndrome, and especially so we have to look for the patients, especially in patient with the history of drug allergy. Like for example, so many girls or females, they use the mefenamic acid for their menstrual syndrome dysmenorrhic pain to relieve that. And many patients, they are using diclofenac and any NSAIDs for any mild or moderate pain. So we have to look for that dress. While ibuprofen reported 233 cases, but still shows a low disproportionality ratio. But its high number of reported cases highlights its public health relevance due to its widespread use, because ibuprofen is given to every kid. है ना? We know this. So, next is for the diclofenac, naproxen, acetaminophen, and aceclofenac, whether there were number of DRESS reports were maximum 150 for diclofenac, acetaminophen was 149. But if we see the PRR value, that was less than 2, 1.8. So it did not complete the Evans criteria according to which we could associate. So these all drugs showed the non-significant association with the DRESS syndrome. So in conclusion, this phase-based pharmacovigilance study highlights a noteworthy association between mefenamic acid, piroxicam, meloxicam, and ibuprofen, while other analgesics showed no clear link. So the results emphasize the need for careful monitoring, early recognition, and cautious prescribing of high-risk non-steroidal anti-inflammatory drugs. So future studies should include the prospective trials, genetic profiling, and mechanistic research to clarify the pathway of analgesic-induced stress and guide the personalized risk reduction strategies. Thank you.
Okay. I think we should thank Dr. Minakshi for bringing up this very important and alarming thing, because you know that most of the drugs, whatever Dr. Minakshi mentioned, they all are available over the counter, and now we are so much used to have these medications. But also there was some data where we saw that some drugs are like okay, we can still doctors can prescribe. So
Like
any,
the fixed dose
yeah.
combination of mefenamic acid with paracetamol is banned, but
Okay.
but alone mefenamic acid is not banned. It's still in use.
Okay, that's very important to know. I was totally unaware of these things, and it is because being in Chandigarh for about a decade now, we all have visited maybe GMCH at least once, and we have seen that the institute is really supporting the whole region very well. So I think I would like to invite any questions for Dr. Meenakshi. Yeah, so ma'am, again, I have one question. So, because I wanted to know, actually, it is not a question, like this DRESS syndrome symptoms, because you said that it was available on Open Vigils, the database. So, who maintains this database? And like like what are the symptoms of this DRESS syndrome? So, like how this database is, like, how this data get reported in this, which you actually extracted and presented it.
So this data was openly accessible in the public domain in FAIRS, FDA-based data, and there was no such identification mark for the patient name or address, etc. So there was no need to take any ethics approval, ethical approval. And secondly, the symptoms of DRESS, which is with the non-steroidal anti-inflammatory drugs, the symptoms appear after 2 to 6 or 2 to 8 weeks of the drug exposure, and the main symptoms like scalded skin will be there, there is a rash with a high number or severe eosinophilia, like more than 1000 cells of eosinophils.
Okay.
And there will be many other organ damage like liver, kidney failure can be there, and so many manifestations of skin related manifestations.
Okay, so that means mostly the clinicians they report this data, and from there the data goes to the database. Yeah, yeah. I remember when I was a kid, my sister used to get issues with whenever she will have ibuprofen, and then we realized that there is some kind, but I was not aware about this. Yeah.
Mefenamic acid for dysmenorrheic pain.
Okay.
Then when IPC issued the advisory for this issue, then I thought I should not use them.
Okay. Good. Thank you. I think we all should thank Dr. Meenakshi.
Thank you.
Now I request our session chair to kindly facilitate Dr. Minakshi. Please go. Now I request our next presenter, Dr. Karanjit Tripura. भारी हो गया बाहर बाहर बैक डेस्कटॉप पे इनमें से होगा कोई ये होगा ये देखिए
ये भी है सर, एक वो भी चल रहा है वैसे, ये भी है, ये भी है, चलो आगे बढ़ते हैं। ये भी So thank you to the organizer for giving me this opportunity. So, so I'm Karanjit and I'm pursuing my PhD at National Agri Food and Biomanufacturing Institute. So today I'll be sharing some our works. The title is vitamin A deficiency induces sex-specific alteration in gut microbiota composition and also some metabolic function. So we all know the sexual dimorphic dilemma. Even though there is evidence of sexual dimorphic result in various biological samples, the role of sex in biomedical research is being overlooked. And of course, various metabolic complications can arise due to genetics, then hormonal and uh, the microbiome, or different lifestyle, or the dietary intake that we take. For example, say like micronutrients, vitamin A. So vitamin A, we all know it's important in the preventing blindness and maintaining immune system, also in lipid metabolism. So in our study, we try to check what is the complication of vitamin A deficiency between male and female. So as you can see in this in the figure A. So we have divided both male and female into two groups. In the one group, we have supplemented with vitamin A sufficient diet, and in the another group, we have given them the vitamin A deficient diet. Then we went for the multi-omic studies, like correlating various data of serum metabolomics, metagenomics, and various other metabolic results. So as you can see in the figure B, the female reached the vitamin A deficiency threshold earlier compared to male. Even after sacrifice, you can see in the figure C, there is a decrease in the vitamin A levels in the liver also, because liver is the storage primary storage organ of the vitamin A. So next we also see, like, try to analyze if there is any changes in the vitamin A homeostasis gene. So you can see in the figure E, there is significant down regulation of vitamin A dependent gene like RA at beta or CYP26A1. So the role of CYP26A1 is that it used to degrade when there is excessive retinoic acid in our body. So one interesting finding that we have found is that there is a uh, sexual dimorphic expression of retinol binding protein 4. So this RBP4, the main role is it used to carry out all those retinol from the liver to different organ. So in next we also saw there is a sexual dimorphic
alterations in the gut microbiota. For example, see, you can see here in case of male there was higher alpha diversity, but in the female there was almost similar result. And in the at the phylum level of the gut microbiota, you can see there was increase in blood microbiota in vitamin A sufficient male, but in deficient male it decreases. But at the genus level, you can also see there is higher levels of Akkermansia in case of sufficient male, but it decreases in the vitamin A, what is it, deficient male. But again, in case of a female, you can see there was a lower level of microbacterium, which is again a type of pathogenic bacteria. But in case of deficiency female, there was an increase in microbacterium. So again, there you can see in the abundance of different bacterial phylum, like uh, the abundance of Bacillota was lower in case of female, but higher in case of male. And even if you look into bacteriotes, it was higher in case of deficiency male and lower in case of sufficient male, but almost similar in case of female. So again, the ratio was also difference. It was the Bacillota by Bacteriota ratio was again higher in case of sufficient female, but again not in case of deficient male. So we also did the functional annotation of various these microbial capabilities, and we found like different three significant pathways, like say fructonate degradation and pyruvate fermentation to butane. So this pathway actually increase the energy uptake and can cause lipid metabolism dysfunction. So this pathway are also found to be elevated in various cecal meta content or cecal content metabolomics of various type 2 diabetes patient or having or patient having obesity. But this pathway was again absent in case of male, again showing a different like sexual dimorphic result between male and female cecal metabolic capabilities. Next, we targeted the adipose tissue. As you can see, there was no sharp decrease in the retinol concentration in the adipose tissue, but the vitamin homeostasis gene was again affected here. Also, there was triglyceride levels were higher in case of male, but not in case of female. And in case of fatty acid, again, palmitic acid was lower in case of female, but not almost similar in case of male. So again, showing some sexual dimorphism. But if you look into adipose tissue morphology, you can see like bigger size of the adipocytes. So this means that there is an increase in the fat content, which again giving us hint that during vitamin A deficiency, this lipid metabolism dysfunction occurs, and uh, you saw increase in lipid accumulation in the adipose tissue. So again, if you also look into adipocyte cells, the cells were bigger, as you can see from the graph. In case of female, again showing that the incidence of lipid metabolism dysfunction was severe in case of female. So then we to further check, we did a serum metabolomics, and we found there Belin, which is actually a metabolic symptom, a metabolic sign of increase in inflammation and oxidative stress. So Belin was also increase in like patient like type 2 diabetes and some insulin resistant patient. So another thing is we also found higher glucose level in case of female, again showing that like in female the energy metabolism was high, altered compared to that of male. Also, we have also found like lower levels of short chain fatty acid like butanoic acid, acetic acid in case of vitamin deficient female. So again, if you remember, this short chain fatty acid are the product of microbes that helps in preventing obesity or maintaining controlling this lipid metabolism. So this data correlates with the sickle metabolite. So again, if you look, the sickle metabolite content of this short chain fatty acids are lower in case of deficient female. So again giving us hint that the female might be more affected in vitamin A deficiency condition. So coming to my summary, we have given the vitamin A deficient diet to both male and female, and we found sexual dimorphic gut microbiome alteration. There was also increase in pathogenic bacteria, although I have not shown many of the data. So also there was lower levels of retinol binding protein 4 that actually hampers the transportation of vitamin A from the liver to other organ. Also, there was early onset of vitamin A deficiency in female. So overall, the result give us that female might be more prone to obesity under vitamin D deficiency condition. So these are the preliminary work that we have to do. So first of all, I would like to uh, thanks to all my lab members, my co-advisors, Dr. Tiwari. So in our lab, Dr. Tiwari have also developed this vitamin A biofortified golden banana. So it was sponsored by the BIRAC program. So all the work that I have shown was a part of their project. So where we want to see that what happens to this vitamin when a person become vitamin A deficiency, and we in the next future experiment we will use this vitamin A enriched banana biofortified banana, and to see that whether eating this biofortified banana can cure all this vitamin induced deficiency. So thank you.
Okay. Thank you again. This was another very interesting talk, and Karanjit nicely presented huge data where they have shown that how vitamin A deficiency is related to the sex, and then how it is very important to take care of this deficiency, and how it is actually related to the lipid metabolism dysfunction. So, any questions? Any questions from the audience? Any, okay. Okay. So, Karanjit ji, I have one question. So you mentioned about lipid metabolism dysfunction.
Yes.
So vitamin A is related to that, or
Yeah.
lipid metabolism dysfunction is also related to vitamin A deficiency.
So one of the product that forms out of vitamin A is normally when we call vitamin A, it's retinol. But no one's the main active form of vitamin A is retinoic acid. So what this retinoic acid does is this retinoic acid can go and activate various transcription factor and activate various genes that control this lipid metabolism or pathway or whatever. So because there is a decrease in vitamin A level, so there should be decrease in the retinoic acid also. So if there is lesser retinoic acid, so all those what to say what all those genes that are involved in lipid metabolism won't get activated. So that's why we are getting this effect.
Okay. And one more question. What is the dose? Because you said that you looked at the mouse models.
Hmm.
So what kind of dose you were giving to mouse?
So it's a rat.
Yeah,
So
in the rat model. Yeah.
so we bought this diet from Germany, Altromin International. So it's a standard diet, and
Okay, the standard. How
so
much is the
yeah.
vitamin
So
A?
in the sufficient, it contains 15,000 international unit of vitamin A.
And then for the deficient
So it doesn't
vitamin A,
contain any vitamin A
so that is also you get it or you
from the
prepare that
same vendor, same
same
manufacturing.
vendor. Acha. Okay, so this is why this was available from this vendor. This
Uh,
kind of a meal without vitamin A.
you
Or
want
is
to
this
get this?
like
Uh,
what was the reason that why these companies actually making this vitamin A deficient?
no, they also sell lots of other diet like gene deficiency, vitamin B deficiency. So they are established brand in making all this diet.
And do you also check whether the
Yeah,
vitamin
yeah, we
A
used to check.
percentage?
Yeah, we have HPLC machine, or we can analyze, we can quantify all this vitamin A in LC using LC.
Okay, thank you. I think this was very interesting.
Now I request our session chair to kindly facilitate Dr. Karan. Our next speaker for oral presentation is Dr. Shivani Bhardwaj from NIPER.
A very good noon to the respected chair, faculty members, and my uh, fellow researchers. My name is Shivani Bhardwaj, working under the guidance of Dr. Sapna Kushwaha from NIPER Raebareli. The topic for my talk is assessing time-dependent senescence and fibrotic changes in bleomycin-induced model of pulmonary fibrosis. Now, first of all, what is pulmonary fibrosis? It is a chronic and progressive interstitial lung disease which is marked by deposition of extracellular matrix and leading to distortion of alveolar structure, and finally which leads to pulmonary failure or respiratory failure. Now it predominantly occur in older patients like after 50 years of age. So we can consider that the senescence or aging could be a possible driving factor for the pulmonary fibrosis.
in the lungs of IPF patients, both 82 cells. Now there are two type of cells present in the lungs, 82 cells and 81 cells. 82 type cells are progenitor cells, which are further converted into 81 cells, which perform the gaseous exchange. Now these 82 cell, when they become senescent, they release SASP, which are senescence associated secretory phenotypes, which leads to immune cell infiltration and further release of many profibrotic and pro-inflammatory factors, which further leads to activation of myofibroblast, which are converted from fibroblast to myofibroblast. Also, clinically, elevated SASP mediators like MMP7, growth differentiator factor 15, activin A, these are found in the bulb, that is bronchoalveolar lavage fluid of fibrotic patients. Now, the hypothesis was we have used bleomycin as an inducer to induce pulmonary fibrosis, linking the senescence pathway. The pathway includes the P53 and P21 pathway, where P53 activates P21, which further inhibits the cell division. Now, cellular senescence is all about the stoppage of cell division. The cell will remain metabolically active, but it will not divide. It releases SASP, which will further leads to infiltration. Now, the my study design was in vitro. I have used A549 cells, where I have conducted many assays like MTT, biochemical assays, SA beta gal staining, which is a biomarker for cellular senescence, and Western blotting. In vivo studies, I have used C57BL6 mice, where I have intratracheally administered bleomycin 2 unit per kg, and we have performed sacrifice at 7, 14, and 21 days, and carried out biochemical analysis, SA beta gal staining, histological analysis, and Western blotting. So the in vitro study results include the cell viability. As we can see, there was a dose-dependent decrease in the cell viability when we have when we have treated the A549 cells with bleomycin. Uh, the SA beta gas staining, as we can see, there was more number of blue stained cells at doses of 50 and 100 micromolar, indicating that there is a more senescence at higher doses of bleomycin. Further, the antioxidant parameters like GSH level and SOD activity were decreased in a dose dependent manner, and the lipid peroxidation level were increased in higher doses. Further, we have conducted Western blot analysis, where the senescence marker like P53, CDKN2A, and CDKN1A were also increased in a dose-dependent manner. And with this senescence marker, the fibrosis markers were also found to be increased in a dose-dependent manner. Further, the effects were evaluated in C57BL6 mice, where we have observed the body weight changes at day 17, 14, and 21. Initially, the body weight was not changed significantly, but at day 14 and 21, it was decreased significantly. And the lung weight was found to be increased, indicating that there could be lung injury, which leads to increase in the lung weight. The lung index was also found to increase at day 14 and day 21. The antioxidant level were found to decrease during the day 14 and 21, whereas the MDA level were found to be increased. Further, we have conducted the histopathological staining, where the HNE, the day 14 showed that there was increased infiltration of immune cells, and there was more distortion in the alveolar structure. And in the PSR staining, we can see there was more collagen deposition at the day 14, but it was found to be cop up at the day 21. We have conducted Western blot analysis, where the senescence marker were found to increase during the initial days of our administration, like at day 7 and day 14. We found that P53 and other markers of senescence were increased, but during the day 14 and day 21, there was an increase in the fibrotic markers. From here, we can conclude that the senescence could be a factor which lead to the fibrosis. So, coming to the conclusion, the bleomycin effectively established a senescence-associated fibrosis model, as shown by a dose-dependent decrease in A549 cell viability and strong SA beta gal positivity. The senescence markers like P16, P21, and P53 were markedly upregulated, confirming activation of DNA damage-driven cell cycle arrest pathways. And the fibrotic proteins like alpha SMA, TGF beta, and collagen 1, they were also found to be increased, indicating that bleomycin induced senescent epithelial cells, contributing directly to the profibrotic remodeling. Thank you.
Okay, thank you, Shivani. I think again we all see a very huge, like a very interesting data on pulmonary fibrosis, where Shivani looked into the bleomycin's effect on this. So, any questions for Shivani? Yes. Yeah, that was the one thing which I just wrote on my sheet. So that rationale was missing. So yeah.
Actually, bleomycin is an anti-cancer drug, but it was found to cause lung toxicity. So, in many models, they have generated pulmonary fibrosis using bleomycin. It is a standard model for pulmonary fibrosis. What I have done is I have checked whether it is doing this by the way of cellular senescence or not.
Compared to other models, what is the distinct difference between the models? Like which model will be validated compared to other infection diseases, outward diseases?
Okay.
How you are making just taking advantage the model finder, the better model finder? How you would recommend?
So as we know that bleomycin is working through DNA damage responses. When these responses are generated inside the cell, they lead to accumulation of senescence like P53 and P21 markers. These are induced when there are DNA damage responses and oxidative stress. So
Okay, for example, compared to other model of blueprint, what is the day difference of between the administration and whether in such a case whether it's able to take any rational? Suppose in another model in which you are using the new extra better class suddenly 50 days it's going to whether in your model you are saying that up to taking 30 days
7, 14, and 21 days.
Yeah.
whether which whether it is finalized that compared to that which aspect it is good your body is better for that
Yes, from my results, I have seen that during day 14, there is the peak of fibrosis. Like all the fibrotic markers were at the peak on day 14, but during day 21, it was found to be decreased. Like from like
Yeah, I want to add that what was your control? It was all without bleomycin.
no, it was one was controlled that is with normal saline only, and others were with bleomycin. Like I have kept for control for day 7, control for day 14, and control for day 21. As it was a aging related study, so I have kept 3 controls at day 7, 14, and 21.
There was no any positive control as such, like anything similar reported earlier, like bleomycin.
Uh, Sir, actually, this is only for model generation study. Now, I'm proceeding this work with a drug. Like, I'm going to treat. Like, there are two type of drugs: senolytics and xenomorphic. Senolytics are they will specifically kill the senescent cells. So, I'm going to target that pathway with the drug. So, this is my PhD work, and I will continue this.
Okay. Yeah.
Yes, sir.
compare that other to other how better and whether it is reducing a to the timeline reduction for example 48% of fee that could be maybe mentioned in your conclusion that so compared to other models the 50 days where we have observed in the peak level of the record and then in 15 days maybe
Yes, sir. It is reduced.
that is that it is
Yes, sir. It is reduced.
so that way you can if you are concluding that you can validate your model then that will be the
Okay.
Okay. I think thank you. It was very interesting discussion.
Thank you.
So yeah.
Thank you, Dr. Shivani. Now I request our chairperson to kindly facilitate. Dr. Shivani. Now I request all the speakers to come on the dais to facilitate our chair of this session. all the speakers. Kindly give a round of applause. Thank you, sir. Is Lakshmi Kant Purane is there in the audience? Lakshmi Kant Purane. Oh, Roman Preet Kaur in the audience.
का सब गाड़ी पहनी और गाड़ी पहनी विनीत रुका है विनीत पानी पानी खत्म हो गया मुझे ओरल प्रेजेंटेशन में भेजिए एक मिनट मैं उनको कॉन्फ्रेंस कॉल में लेता हूँ आप उनसे बात करिए
Is Lakshmikant Rane is there in the audience?
कितने है पानी में
Good afternoon, everyone. Now we have another session for the oral presentation. Now I would like to invite chair of for this session, Dr. Ravi Pratap and Dr. Pavitra Ranawat from Department of Biophysics, Punjab University, Chandigarh, and Dr. Dinesh, Senior Director and Head Jubilant Pharma. I welcome you all and I kindly request to ascend the dais. Dr. Dinesh, welcome you all. Cheers. Our first presenter is Dr. Akhila Ajay.
Good morning, respected faculties and all of the audience. Today I am going to present a topic in oral presentation that is assessment of knowledge, attitude, and practice of nutraceuticals and nutrivigilance among medical undergraduates and postgraduates. Next page down. Introduction. Nutrivigilance is defined as the science and activities relating to detection, assessment, understanding, and prevention of adverse effects related to the use of a food, dietary supplement, or medical food. Nutraceuticals are considered as foods by the FSS Act 2006, Rules and Regulations 2011. FSS regulation of 2016 provided guidelines regarding nutraceuticals along with health supplements, foods for special dietary purposes, foods for special medical purposes, that is FSMP. Next is the nutraceutical shall contain any of the ingredients specified in the Food Act. There are total 8 schedules. Schedule 1 is vitamins and minerals. Schedule 2 is essential amino acids and other nutrients. Schedule 3 is values for vitamins, minerals, trace elements allowed for the use in FSDP and FSMP. Schedule 4 is list of plants and botanical ingredients. Schedule 5 is food additives. Schedule 6 is list of ingredients as nutraceuticals. And Schedule 7 is list of strains as probiotics. Then Schedule 8 is list of prebiotic compounds. Next, since last few years, food supplements manifested an upsurge through the world, including India. Use of nutraceuticals has gained importance in recent times owing to COVID-19 pandemic and overall focus on health. This has led to over-the-counter use of health supplements. With availability of online options, more people are consuming nutraceuticals without professional guidelines, which may turn out to be the serious public health issue. Hence, there is need for the healthcare professionals to be vigilant about the adverse effects produced by these nutraceuticals and also educate the public regarding rational use of nutraceuticals. Aims and objectives of this study. First one is to assess the knowledge, attitude, and practice of nutraceuticals and nutrivigilance among the medical undergraduates and postgraduate. Specific objectives were determining nutraceutical knowledge and attitudes regarding nutrivigilance. An additional goal of the study was to determine participant awareness of the nutravigilance. Methodology. A structured questionnaire consisting of 20 questions were shared through the Google Forms was used to collect the data on knowledge, attitudes, and practice in nutraceuticals and nutrivigilance. The collected data was analyzed using MS Excel. The study design was a cross-sectional study and study period was 1 month 1 month conducted in August 2025. Study population was taken as medical undergraduates and postgraduates. Study center in the Institute of Medical Sciences and the sample size came as 246. These were the questions. First one is knowledge related questions. I will read the questions. Are you aware of the words nutraceuticals and nutrivigilance? What is the regulatory authority for food products in India? The dietary formulations intended to supporting nutritional needs of persons with disorder or disease are called. Who can take health supplements? Can nutraceuticals and health supplements claim to cure or prevent a disease? Have you ever experienced or came across anyone having any side effects or adverse reactions after using whey protein supplements? Then attitude related questions are: is it right practice to sell vitamins, mineral supplements, protein supplements over the counter? Do you feel there is a need for regulatory authority to monitor adverse effects of the nutraceuticals? Do you feel that adding health supplements to prescription improves the overall prognosis of the patient? Can dietary supplements be used as a complete replacement to food? Do supplements have beneficial effect in lifestyle disorders like obesity, hypertension? If any nutraceutical products claims to cure a disease or modify parameters, should it be subjected to clinical trials? Should post-marketing surveillance be done for health supplements or nutraceuticals in the way it is being done for the drugs? Do you think advertisements on social medias regarding nutraceuticals is good? Next is the practice related questions. How frequently do your patients come to you for suggestions about the health supplements they want to take? And second question was, how frequently do you prescribe supplements, prebiotics or probiotics to your patients? So the conclusion of this study was, this study shows that the awareness about nutrivigilance is less among the participants. On average, only 41.5% gave correct response for the knowledge-based questions. This calls for the conduction of sensitization program about the use of nutraceuticals and nutrivigilance for medical undergraduates and postgraduates. The overall attitude of the participants towards the nutrivigilance is positive, with 83.7% believing there should be post-marketing surveillance for nutraceuticals, and 89% feel there is need for regulatory authority to maintain the adverse effects of nutraceuticals. These were the references. Thank you.
Hi. So nice presentation, and you have comprehensively covered neutrovigilance, and wherein you have carried out studies on 246 sample size, right? So your most of the conclusions, so 80 to 90% were related to some aspects. So what are the three major highlights you can suggest in terms of patient compliance,
Yes.
patient improvement, and future recommendation for the regulatory agency to draft?
Sir.
Thank you.
Limitations are there for nutraceuticals. That is, overuse can lead to toxicity, and quality will be variable again among brands. And then regulatory authority also they have to take care of this all these nutraceutical products. Limitations are there, and there's a growing trend in the market.
Have you seen for which purpose they are taking? How does people
Yes. Yes. So actually, it is not needed for a person taking balanced diet. It is actually prescribed to patients having, like, for example, cancer patients, malnourished patients, or elderly patients. They can take as a health supplement, which can add nutritious to their health. Other than that, a person taking balanced diets, there's no requirement for taking nutraceuticals.
Uh, you already talked about the sample size, right?
Yes.
So how did you decide 246 or whatever number you want to work with?
Sir, it's randomly, like, I've shared the questionnaire form,
Okay.
like that only I've taken.
So now my point is, how did you figure out that you want to work with 246 samples? I mean, you could have worked with more or even one sample, right? What was the genesis of 246 number?
There is nothing like this, sir. That I just ran here done. 246 it came out. Thank you, sir.
Now I request the chairs to kindly facilitate. So please. Give a round of applause. Our next speaker is Dr. Sunil Korde from Pune.
Very good afternoon to one and all here. And my heartiest thanks to IPSCON for the wonderful arrangements over here for the conference. Let me introduce myself. My name is Sunil Kordi. I am from Singat College of Pharmacy, Pune, and also associated with Serum Institute of India, a vaccine manufacturing organization. And my topic of the research today is the utilization of BCG vaccine in type 1 diabetes. So as we all are aware, the type 1 diabetes is an autoimmune disease in which the body's own cells destroys its own pancreatic beta cells, and there is a lack of insulin which moves the glucose into the cells. So the glucose utilization state per se is disturbed in type 1 diabetes. And we all are aware of many insulin injections that the novel the approaches that that currently we have adopted. Insulin is there, a lot of drugs are there, and there is a lot of development in therapeutic segments with respect to the immunosuppressants and cytokines having their own drawbacks. So with this all said, we have tried to evaluate a novel and natural source of something, that is the BCG vaccine, which could ameliorate the disease status in type 1 diabetes. So let me go to the history of this, why we identified BCG vaccine. There are a lot of clinical research, preclinical research taken place earlier with respect to complete fluent adjuvant that you all are aware. There are a lot of NOD mice, NOD mice, that is a non-obese diabetic mice, in which the complete fluent adjuvants have been shown as a natural inducer of tumors necrosis factor and known to reduce the ameliorate the disease status in the NOD model, NOD mice models. So with this concept, we tried to evaluate the BCG vaccine in type 1 diabetes. And as we all are aware that BCG vaccine is basically a 100 years proven safe vaccine, basically used in tuberculosis. Although in the recent 40 years, this BCG vaccine is also being utilized for the early stage of urinary bladder cancer, safely used in non-muscle invasive bladder cancer, 40 years. And now there is a lot of research, clinical, it has also already entered into clinical trials to ameliorate the type 1 diabetes. So although there is a lot of preclinical and clinical research, it is a very much controversial subject with respect to timing, dosage of administration, and various other things. So with this BCG introduction, the key benefit in introduction of BCG is once you introduce the BCG with a single dose or a two dose, you don't have to give it permanently, and it reduce. Although it takes some time to induce the anti-hypoglycemic effect, there is a permanent. Oh, sorry. It's moving here, but not there. I can see. Not moving. Yeah, it's not moving. It's okay. So as I said, the various why we are into this. So there is a lot of strain differences with respect to efficacy of the BCG vaccine also, and that is why the primary reason we are again exploring this BCG vaccine in type 1 diabetes. So we have done a lot of preclinical research as well as the various clinical research, and we have published some manuscripts also. Here is, as you can see, in the diabetes, the cytotoxic T lymphocytes lymphocytes are predominant in the micro and autoimmune environment. But with the induction, with the introduction of BCG and the induction of tumor necrosis factor, the cytotoxic lymphocytes are destroyed and increasing the T regulatory cells. The T regulatory environment, which is beneficial in the regeneration of beta cells, is created over here. Similarly, there is an autoimmunometabolic effect also which takes place with respect to introduction of BCG, which shifts the poor glucose utilization state, which is predominant in diabetes, from the oxidative phosphorylation to the higher glucose utilization state, that is the aerobic glycolysis. So with this, we have utilized two models, that is zebrafish and the mice model, for these studies. As you can see here, uh, in the zebrafish models, with respect to the control, where there is a high sugar glucose levels, with the introduction of the BCG, the single dose with 3 microliters and 6 microliters we had started with, there is a predominant anti-hyperglycemic effect as compared to the standard control. And even in the same therapeutic group also, we have observed anti-hyperglycemic effects. Although you can see that we have also in the BCG control group, the last group, as you can see, there is a hypoglycemic effect which we have also observed. So this is one of the area which we want to pursue further, why there is an hypoglycemic effect in the normal BCG control group also. Similarly, the mice models, these are the plots of the results that we have got in mice. Similarly, here also we have used single dose and double dose models in the prophylactic and only the single dose in the therapeutic, wherein also we have got the anti-hyperglycemic effects in the mice model also. To extend further, we estimated the glycolylated HbA1c levels also in the mice models, wherein the similar reduction in the HbA1c levels were observed in both the prophylactic and therapeutic interventions. So with these studies, we are now trying to update our dose levels from the higher dose of 6 microliters to 3 microliters, 1 microliters and 0.5 microliters, with additional estimation of the gene expression studies for preproinsulin, TNF alpha, and other insulin expression factors, pancreatic factors. So this is the way we are trying to do about it, and we have observed the beneficial effects in both the models. So with this, we would like to further carry out our studies with respect to immunological and metabolic estimations further, including the transcriptional and translational studies. And we would like to fully understand the mechanisms through which BCG exerts its actions through through differences in their various strains of the BCG vaccines with respect to alteration in glucose metabolism, pancreatic beta cell preservation or regeneration, or whether it is direct immunomodulation. So with this, I stop here, and I would like to thank all my team here at this college as well as my institute with respect to contribution for my. So thank you.
So, Neil, why did you choose two different models, zebrafish and mice?
Yes, actually, um, we we did it in the mice model, but in, uh, already had an established zebrafish model, in diabetic model in our college. So we want to additionally explore the similar studies in zebrafish models also.
And what kind of mice did you use for the study?
Swiss albino mice.
Okay. And what was the sample size and other things for the mice? I mean, how many, total number of animals you had?
Mice per group.
Okay. And did you see any mortality or something like that?
Pardon?
Did you see any mortality?
Mortality, yes. Only one mice was we have got a mortality. Otherwise, it's a safe. Uh, per se, the streptozocin model is well established in mice as well as zebrafish. So only streptozocin or something else along? No, only streptozocin. Incited buffer. And no.
Can you guess what you
No, because this BCG vaccine doesn't work, will not work in type 2 diabetes because it's an lifestyle different mechanism, and this with a natural indicator of tumor necrosis factor being an autoimmune disease, we are focusing on that. So, yeah.
Did you also supplement the animals following this receptors? It was an injection, the very glucose, high concentrations of glucose solution?
No, you're right, ma'am. Actually, the gold standard in the test that we have not done that.
No, no, but did you supplement their diet with glucose solution?
Yeah.
Because in the STZ model, the standard protocol states
Yes.
after the STZ injection, the following day you have to supplement the animals with the concentrated solution of glucose. That is how you get the balanced high levels of glucose in blood. Otherwise, they fade away. For 24 hours, every 6 hours, you have to supplement the high concentration of glucose. So, आपने नहीं किया? Did you? Right. You can maybe check.
Yeah, I'll check. Thank you so much.
Okay, Sunil, excellent presentation. Just few questions. So, what will be the final commercial formulation, and what will be the strength, and what will be the frequency of the dose?
It is what we are working out actually, because as you see, BCG, if you say dose-wise, only 1 microgram is used for induction of immunity in tuberculosis, whereas 40 microgram dose is used in cancer, urinary cancer. So right now we are in the stage of the preclinical studies, and we are trying to still optimize our dosage levels in those two models. Because since we have observed a hypoglycemic effect in the zebrafish model, in the control group also, in the BCG control group also. So from 6 microliters, we have to come down to 3 microliters and 1 microliter and 0.5 microliters, the zebrafish model. So depending upon the success of those studies and optimization, then we would like to evaluate the dose for the clinical or translational purpose. Along with that, we have other concepts also, like recombinant BCG is also coming up in this field. So we would like to utilize that.
Okay, okay, thank you.
Thank you.
Now I request our session chair to kindly facilitate Dr. Sunil. Our next speaker for oral presentation is Dr. Romanpreet Kaur from ISF College of Pharmacy, Moga, Punjab.
Good afternoon, one and all present here. Myself, Romanpreet Kaur from ISF College of Pharmacy, Moga, and today I'm here to present my oral presentation. And the title of my oral presentation is Neuroprotective Role of Glabridin to Mitigate Titanium Dioxide Nanoparticle Induced Cognitive Deficit in Adult Zebrafish, targeting NRF2 and HO1 signaling. So, move to the introduction part. As we all know about the cognitive deficit, it's a impairment in an individual's mental process that leads to acquiring information and knowledge, but affects various aspects of cognitive function, including memory, attention, judgment, and decision making. And the toxin we have used was titanium dioxide nanoparticles, which are widely used in the sunscreens, paints, UV protection, self cleaning surfaces, but it has potential to cross the blood brain barrier and have neurotoxic risk, which may lead to the neuronal damage and impair the neurogenesis, which results in the behavioral deficit like anxiety and cognitive impairments. Next, the treatment drug we have we have taken was glabridin, which is a flavonoid extracted from the licorice and has antioxidant and anti-inflammatory properties. Also, it has neuroprotective properties. Next, move to the aim and objectives. So, the aim is neuroprotective role of labradine to mitigate the titanium dioxide nanoparticle induced cognitive deficit in adult zebrafish targeting NRF2 and HO1 signaling. Objectives are to find the neuroprotective role of labradine in titanium dioxide nanoparticle induced cognitive deficit model through analysis of behavioral, neurochemical, and neuroinflammatory markers, to confirm the protective effect of labradine by targeting NRF2 and HO1 signaling, to find the histopathological changes in brain and immunohistochemistry of NRF2 and HO1. Next, move to the material and methods. So we have taken total 84 zebrafish. In each group, we have taken 12 number of zebrafish. First group was control group, second is titanium dioxide nanoparticle, then glabridine 12.5 mg per kg, glabridine 25 mg per kg, glabridine 50 mg per kg, donepezil 1 mg per kg, and NRF2 inhibitor 30 mg per kg. This is the timeline of my experiment. So the experiment was of total 7 days. Next, move to the results and discussion. First is the effect of labradine on NORT, which is Novel Object Recognition Test, and T-maze in titanium dioxide nanoparticle treated zebrafish. First graph shows the Novel Object Recognition Test. So in this, exploratory time was more in the treatment group as compared to the toxin group, and here are the track plots are also mentioned. Next we have T-maze. In this, the transfer latency to favorable zone is more in the toxin group as compared to the treatment group. So by the treatment group, the transfer latency to move to the favorable zone was decreased, and when we compare to the toxin group. Next is effect of labradine on novel diving test in titanium dioxide nanoparticle treated zebrafish. So in this, number of entries in top zone was significantly more in treatment group as compared to the toxin group, and the time spent in bottom zone was significantly decreased after given the titanium dioxide 50 mg per kg when compared to the toxin group. Next, move to the effect of labradine on biomarkers, on biochemical parameters. So in GSH, by giving the treatment group, the level of titanium dioxide was decreased. Sorry, the level of GSH was decreased in titanium dioxide group as compared to the treatment group. Next, in MDA, when given the treatment group, the level of titanium dioxide was increased as compared to the treatment group. Next is SOD. The SOD level was increased when given the treatment group as compared to the toxin group. In ACHE, the level of ACHE was decreased with the treatment group as compared to the toxin group. In GPX, the level of GPX was increased with the treatment group as compared to the toxin group. And last is catalase. The level of catalase was increased with the treatment group as compared to the toxin group. Next is effect of labradine on neurotransmitters in titanium dioxide nanoparticle treated zebrafish. So first graph is glutamate. In this, the level of glutamate was decreased after giving the treatment group, and in GABA, the level of GABA was significantly increased after giving the treatment group. Next is effect of glabridin on pro-inflammatory markers in titanium dioxide nanoparticle induced zebrafish. In this, three inflammatory markers was checked. First is TNF alpha, second interleukin 1 beta, and then interleukin 6. And in three cases, the level of these pro-inflammatory markers was significantly decreased after giving the treatment group as compared to the toxin group. Next is effect of glabridin on the neuronal morphology. So as we can see in the slides, the pycnotic neurons are more in the toxin group, but after giving the treatment, the number of pycnotic neurons was decreased. Next is effect of glabridin on NRF2 and HO1 in titanium dioxide nanoparticle treated zebrafish. So in this, the percentage of NRF2 positive neurons are significantly increased after giving the treatment group as compared to the toxin group. So move to the discussion part. In this study, glabridin shows the potential to improve the cognitive function in titanium dioxide nanoparticle treated zebrafish by stimulating NRF2 and O1 signaling. Summary and conclusion. Titanium dioxide exposure was observed to successfully cause cognitive deficit and biochemical, neurochemical, and inflammatory and histopathological changes in zebrafish. Glabridin dose dependently effectively attenuates the oxidative stress and neuroinflammation by activating the NRF2-HO1 signaling in titanium dioxide nanoparticle zebrafish model of cognitive impairment. These are the references. I would like to thank my college and this university to giving me this opportunity. Thank you.
So, Roman Preet, what part of the brain tissue that you used? What was the part?
Cortex.
Cerebral cortex. Why not hippocampus?
Because we have to check the cognition and memory.
I think memory and cognition both go very well with hippocampal area. And your slides also show the same. Isn't that true?
Ma'am, slides was of cerebral cortex and as well as hippocampus also.
दोनों थी ना
Yes, ma'am.
dentate gyrus दिख रहा था ना उधर साइड
Yes,
में.
ma'am.
So I think you should concentrate more on the hippocampal area if I'm not wrong. If you are working on memory deficit and cognitive behavior, I think cerebral cortex is ज़्यादा अच्छा. Hippocampus will give you better results. I mean, you can take into consideration that.
Okay. Yes.
Now I request our session chair to kindly facilitate Ramanpreet Kaur. Hmm. Is Lakshmi Kant Rane is there? Lakshmi Kant Purane? Hmm. Now I request all the speakers to kindly facilitate our chairpersons for the session. All the speakers.
Speakers present in the audience kindly come forward.
Ramanpreet? Please facilitate. Dr. Dinesh. Uh, Dr. Pavitra. Thank you, ma'am. Next, Dr. Ravi. Dr. Dinesh. Thank you. Uh, Now we end for this oral presentation, and now we conclude for this session before lunch, and all are requested to kindly join for the lunch, and after lunch you will be requested to join for the valedictory and the prize distribution ceremony at the law auditorium. Thank you all. And all students are requested to kindly sit for a while for a photograph.